Darshini?
Yes, sir.
Darshini, you can come tomorrow also. Okay.
Yes, sir.
And join
Yes,
us. Yeah, if you are interested, tomorrow also you can join, and tell your students also to join tomorrow morning.
Sure,
Because tomorrow morning, 9 o'clock we start.
Yes, sir.
Oh, welcome Garima, Angel. Welcome Bandupu, Vetriviran. Nice. Manish. Good. Kirti. Yeah. So already about 80 people have joined Sheshadri. All our people have joined now. Ram, already there are 85 people have joined, Ram.
We'll be starting probably another 30 seconds, sir.
Yeah, we'll start.
Good evening, everybody. I am Dr. Ramasubramanian. I am the chair of the Adult Immunization Subcommittee of the Clinical Infectious Diseases Society of India. The Clinical Infectious Diseases Society of India is an organization where people who are interested in infectious disease have joined together to showcase and improve the awareness and the interventions which are available in infectious diseases in India. And we have been active for about a decade now. And we hope that through such programs, we can improve the interest in infectious diseases and take it to the next level. Along with this, we have today two other societies which have joined together in giving this program on adult immunization, what you need to know in 2021. I have Dr. Muruganathan, who was the president of the API India, who's been a very, very passionate supporter of adult immunization and has been a huge support for me, especially in pushing the message of adult immunization. And we have also partnered with the Tamil Nadu API chapter to bring this all to you. Now, adult immunization is something which unfortunately has not taken much hold. We should understand that typhoid affects almost 1% of the population of India. We know that chronic hepatitis B infects about anywhere between 3 to 5% of the Indian population, and this may lead to hepatocellular carcinoma. We know that infections like chickenpox and hepatitis A, when they occur in adults, can lead in very severe disease. Hepatitis A can lead to fulminant hepatic failure. Chickenpox can lead to a high mortality in adults. We also know that several infections which are actually vaccine preventable, like hepatitis B and human papilloma virus, there are vaccines available, and unfortunately, adults have not taken up these vaccines. And recently, we see that there is a lot of hesitancy and apathy related to the COVID vaccinations also, even though we all know that COVID vaccinations are probably the only way we are going to end this pandemic. So in other words, immunization is a quintessential intervention in keeping us healthy and improving life. In fact, it goes beyond vaccine preventable diseases, and we are also looking at the role of vaccinating adults for antimicrobial resistance and preventing the consequences of antimicrobial resistance. The reason why adult immunization probably hasn't taken hold is that a lot of healthcare professionals, including doctors, are not aware of the importance of vaccinations in adults. The vaccines are not accessible, may not be available. People are worried about side effects. So for all these reasons, the Clinical Infectious Diseases Society and the Subcommittee on Adult Immunization has brought you this program, partnering with Dr. Muruganathan, and the API chapter. Muruganathan is running the Hold Academy now, and the API Tamil Nadu chapter. I would like to also welcome today, along with Dr. Muruganathan, Dr. Painiyappan, who is the Secretary of the Tamil Nadu API chapter and the National API Vice President, and Dr. Avudayappan, who's the state Tamil Nadu State API Chairman, and who's from the Government Erode Medical College. So welcome to all of you, and it is with all your support that we are able to do this. I would also mention the support through educational grants given by Pfizer, Sanofi, and Abbott to make this function possible. So with this brief introduction, I'm going to call upon Dr. Professor Muruganathan to say a few words on adult immunization and his sentiments on what needs to be done. Over to you, sir.
Yeah, thank you, Dr. Ram, for that nice introduction about the adult immunization. My dear brothers and sisters, first of all, thanks to all of you. All our team have joined, from various parts of the country. I see so many attendees who are regular followers of our program. They've joined. I first thank you for joining us. Why we started this adult immunization? Because in 2013, myself, Ram, wrote a book on adult immunization, API recommendations, what we should do in adult immunization. We had been giving talks all over India for so many years. But unfortunately, whenever we give a talk, everybody appreciates, everybody says good. But I don't know whether they're put into action. Is not there. So that is why today we want to have adult immunization for the physicians. First, they should know why we should take adult immunization. And also the awareness is not enough. They should also spread the awareness. One more important thing, even that book in 2013, we have given a chapter how to organize or how to set up an adult immunization center. You see, in the pediatrics, the pediatricians are very good. They always have an immunization clinic with them. But unfortunately, the adult physicians, they don't have the interest to start an adult immunization setup. So two purposes for today. One is, sensitizing and making an awareness among the physicians, thereby all the healthcare workers and all the public. The second important point, today also we are going to have a talk by our Ram Subramaniam, who is a great speaker and a good communicator, how to set up an adult immunization clinic. So I request people who are, in the small towns like Palniappan, you should have an adult immunization center. What all you need, we will tell you. And also we are there to guide you. So that if you have adult immunization, and you should have a protocol, I will request Ram Subramaniam from the Infection Society and myself will give the protocol and the chart. You please hang it in that clinic outside, so that these are the vaccines you should take. So even if you forget, the patients will ask, what is it? Thanks to COVID has done a lot of good things apart from doing a lot of bad things. The one is the awareness of the vaccination is very much there in public. So it is a high time we must strike the iron now. Tell everyone what vaccines you should take during the adult. And people think vaccine means only children. Believe me, according to a news report, more than 95% of deaths due to vaccine preventable diseases in India occur only in adults. Not only that, the morbidity, the disability due to vaccine preventing disease is also huge. Why we need adult vaccination? There are 10 points are there, but I don't want to go into all the details. But the prevalence of vaccine preventable disease is higher among adults than among children. because many diseases once known to affect only children have now been seen among adults as well as, for instance, the sizable diseases burden due to vaccine preventable diseases is responsible for large economic losses directly or indirectly. And certain diseases are vaccines only for adults, for example, herpes zoster, only for adults you should give. Vaccination is an important tool for health management. Vaccination is a valuable investment in health with a positive economic return, good value for money. And reduction of hospitalization. For example, if you take away flu vaccine and reduction of hospitalization, ambulatory care visits, medical interventions are reduced. Even the death rate is reduced. Morbidity and mortality is reduced. Reduction in the treatment prescription. Vaccination can aid in economic growth. Vaccination of older adults will contribute to the promotion of healthy aging and enabling them to assist their family. In fact, the longevity of the students, the elderly people, the changing demography and increase in life expectancy has given birth to the concept of immunization in adults. Even though the current vaccination coverage in adults is poor, there is growing consensus that vaccination is one of the key factors in improving adult health with the aging. There are good success stories about vaccination. Take, for example, polio. Now we are free from polio. So like this, the vaccination will prevent a lot of infectious disease and antibiotic resistance, as Ram said. All that is there. So many advantages. And those of you who are interested to know more about this, I can give you a link by taking that link. There are about 150 pages book. Now we are recently released in Jaipur. So I will send you the link, and whoever wants it, I will put it in the chat box, the link. You can take it, download it, and see what all available, what all the vaccines are there. And Ram and myself were contributing as in the book 2014, and we have an updated version now. So we'll give it to you. So I welcome all the speakers from the Infection Society and also our API members. I also have pleasure in welcoming Vidita and other people all over the country. I see my good followers from the Garima from Madhya Pradesh, Sanjay Shah from Rishikesh, Vidita from Gangtok. So many people are joining. So I'm very happy that the interest for vaccination is now really good. And I request all of you to spread the message and then do your own circle region, some adult immunization regional language, and we will help you reviewing the protocol and also the tabular column. Have a document in every clinic about the vaccination status, just like pediatricians do. We must also start doing. With this, I wish the conference all success. Now I have great pleasure in welcoming today's chairperson, Dr. Avadayappan and Dr. Palniyappan, to take forward, because today we are having good vaccine. One is influenza, second is pneumococcal, third is how to set up a vaccine, and women's health is very important, vaccines for women, and the last but not the least is a very, very important discussion on panel discussion headed by Dr. Ram Subramaniam with all specialists involved, COVID. You can ask any questions on COVID vaccination, combination, mixture, date, all that will be there. So it's going to be a very interesting program today. So I request all of you to patiently listen and then take down the points and also spread the message. And as I said, I will give you the link. You can download your book. With this, I request now Dr. Avadayappan to take over and call the first speaker. Over to you, Dr. Avadayappan. Avadayappan is the Professor of Medicine in Erode Medical College, and he is also the chairperson of the Tamil Nadu API. Dr. Palniyappan is the secretary of Tamil Nadu API. Most likely he is in the car. He may not be there throughout. He has substituted Dr. Darshini Swaminathan, who is the associate professor in Salem Medical College. So now I request Dr. Avadayappan to call the first speaker. Over to you, Dr. Avadayappan. Ram and myself will be always there, but still, please, Avadayappan, go ahead and invite the first speaker. Over to you, Avadayappan. You please unmute, Avadayappan. Please unmute and speak.
Avadayappan, please unmute. Avadayappan. Avaday, please unmute.
Good evening, sir. I like to thank you all for inviting me to join in this meeting. I like to thank special thanks to Dr. Murugan sir. On behalf of API, I wish all the best for the program. And I hope this program, the adult immunization schedule program, CMU program, most useful for the practitioners, as all the physicians and forthcoming doctors. And I wish all the speakers, I hope they will give a lot of innovative ideas and opinion regarding the adult immunization schedule. Nowadays, we have to give importance to the vaccines for adults in various diseases. For example, hepatitis B, and now we are in the pandemic COVID. We are motivating all the people to prevent the pandemic by immunization. So I hope all the topics I gone through, all the topics will be very useful for the delegates. So I wish you all the best on behalf of the Tamil Nadu API, and I'm very happy to invite the first speaker, Dr. Aisha Sumala, for the first topic about influenza vaccines. And I request the secretary, Dr. Palniappan, to very happy with you on this program as a co-chairman. So I request the speakers to continue and proceed the first topic. And I wish you all the best. And
before that, on behalf of Tamil Nadu AP State Chapter, my mentor and guru, happy to be here. I am thankful to my guru, Dr. Wonderful program. Adult immunization program is very, very important. Nowadays, it's very much recognized after the COVID era, because only weapon to reduce the morbidity mortality is vaccination in COVID. From that, we can learn. We have to insist all the diabetic patient, hypertensive patient, any old patient, insist many more vaccination. Especially female papilloma virus, which will reduce the incidence of CS cervix and many sexually transmitted disease, everything. And diabetic and non-diabetic patients, so nowadays the rule of the hour is need of the hour is pneumococcal vaccination. You will see pneumococcal vaccination, influenza vaccination is very, very important to reduce the morbidity and mortality, because not only non-communicable diseases, communicable diseases also taken over to increase the death in India, not only in India, across the world. So adult immunization is very, very important. So each and every one of the physicians should know what injection, what dose, what to do, what not to do, and indications, how many dose, everything. It's very, very important. The first speaker is pneumococcal vaccine. Mostly the pediatrician always give 3 doses of pneumococcal vaccination, but adult we are forgotten. In my clinical practice, even diabetic patients, only 10% of the patients are accepting. Doctor's inertia and patient inertia is there. So now the pneumococcal vaccination current perspective, Dr. Ayesha is going to deliver the lecture. You can ask anything and anything about pneumococcal vaccination after the lecture is over. Over to the speaker, Dr. Ayesha. Sunawala, yeah. Over to the speaker about pneumococcal vaccination, current perspective.
Okay, good evening, everyone. Before I start, may I thank the organizers of the adult immunization update for inviting me to here today. And I hope to do justice to this topic in the next half an hour. My discussion points today, which I'm going to lead you through, will start with a case that describes uniquely the nuances of this illness and highlights the need for vaccination, especially in special risk groups. We're going to move on to a journey from the polysaccharides to the conjugates and back to the polysaccharides in the revised current perspectives and the rationale for the same. We're going to discuss a little bit about high-risk versus at-risk populations for pneumococcal disease, move on to the global and national disease burden of the same, and finally end with strategies ahead as they are. So we'll begin with this case of a 50-year-old lady, known case of rheumatoid arthritis on treatment, who was admitted with cough and fever for a week. She developed dyspnea and purulent expectoration for the past 2 days, and she was hospitalized. Her chest X-ray shown here shows you a right upper lobe pneumonia. Sputum and blood cultures were sent, and she was started on piperacillin, tazobactam, azithromycin, and oseltamivir. The sputum gram stain shows you the characteristic gram-positive lanceolate diplococci. And this is when an ID opinion was sought. We noted that the patient had been on methotrexate and steroids, and she had received rituximab about 5 months before. This is a lower respiratory tract biofire, or the PCR panel, and you can see that it's detected strep pneumonia and influenza A. So I had certain questions to the audience, which I will sort of explain in the next slide. Is strep pneumonia over here a true pathogen in this case? Is influenza A a true pathogen in this case? This illness could have been prevented by pneumococcal polysaccharide vaccine or Pneumovax 23, or it could have been prevented by pneumococcal conjugate vaccine or Prevnar 13. Which of these statements is false? So let's take them one at a time. Strep pneumonia as a true pathogen is correct over here. We had a gram stain showing the same organisms, a clinical syndrome that was in keeping with it. No reason to doubt it. Influenza as a true pathogen perhaps is also correct. We had it on a lower respiratory tract PCR panel, which detects several gram-negative, gram-positive. It's a multiplex PCR as well as 9 viruses with a good sensitivity of over 95%. Specificity may be fraught with a little difficulty and challenges, especially if you have colonizers, but you don't expect influenza A to be a colonizer of the lower respiratory tract. Additionally, we know that 30% of viral pneumonias have a concomitant or secondary bacterial pneumonia, usually diagnosed by molecular methods. And this is because we know that the neuraminidase, especially in influenza virus, can cause a sort of host of changes in terms of ciliary and mucosal damage, cellular and humoral immune system defects, and finally bacterial translocation into the blood. And so you can have secondary infections with strep pneumonia, staph aureus, H. influenza, aspergillus are all important in the post-influenza pneumonia, and now perhaps even in the post-COVID setting. And there have been anecdotal case reports of strep pneumonia post-COVID. Could this pneumococcal pneumonia have been prevented by a pneumococcal polysaccharide vaccine? That is incorrect, and we'll see why. But it perhaps could have been prevented by a pneumococcal conjugate vaccine, as this vaccine prevents nasopharyngeal carriage and protects against pneumococcal pneumonia. So let's understand a little bit between the polysaccharides and the conjugate vaccines. So the polysaccharide vaccines were first introduced in the 1970s, a long time ago. What are the limitations of these vaccines? We understand that the PPSV23 actually covers the most serotypes from all the vaccines currently available. However, it does not reduce nasopharyngeal carriage or colonization. It does not induce mucosal immunity. At one time, the vaccine efficacy or the serotypes covered actually were almost 85 to 90% of all those seen in the community. But recent studies have shown that it's barely 50 to 60% now. And the vaccine efficacy is about 60 to 70% for invasive pneumococcal disease caused by serotypes present in the vaccine at best. There's diminished efficacy in those who are at the greatest need for vaccination, and this is really unfortunate because we know that children under the age of 2, elderly, immunocompromised are the patients who are really at greatest risk, and it's these patients who have poor immunogenicity and cannot mount antibody responses to the polysaccharide vaccine. Additionally, they are T-cell independent antigens, and they do not induce immunological memory and hence have poor long-term protection. However, the immunological properties of the polysaccharide vaccine are changed or augmented dramatically when the polysaccharides are conjugated to a protein carrier. And that protein carrier most often is a non-toxic carrier protein like diphtheria toxin, which has been conjugated to the capsular polysaccharides and produced as PCV 10, 13, 15, and now even 20. So what are the advantages of these? They stimulate mucosal immunity. They reduce nasopharyngeal colonization rates, thereby inducing an indirect herd immunity in the population, even in those individuals who have not been vaccinated. Protection is against pneumococcal pneumonia, acute otitis media, as well as invasive pneumococcal disease. And it induces T-cell immunity and hence has long-term immunological memory. So clearly this looks like the star over here, and it makes the polysaccharide vaccine pale in its comparison look rather redundant. So are we ready to do away with the polysaccharide vaccine? Let's see. So this was the study that really clinched it for the conjugate vaccines. This was a double-blind, placebo-controlled randomized trial on over 80,000 adults over 65 years of age from the Netherlands. And it's the Capita trial. And I'll show it to you in a little greater details. It's difficult to see this table over here, but basically showing you that there was a statistically reduced incidence in infection due to the vaccine type strain for community-acquired pneumonia, non-bacteremic and non-invasive community-acquired pneumonia, as well as invasive pneumococcal disease in these patients who had received PCV13. If we look at the results in a little more detail, there was a 46% efficacy of PCV13 against the vaccine type pneumococcal pneumonia, 75% efficacy against invasive pneumococcal disease. This efficacy, as you can see in this pictorial over here, for both the CAP, the non-bacteremic, non-invasive CAP, as well as invasive pneumococcal disease, showing you that the efficacy was long-standing for a mean of follow-up of about 4 years along the trial period. However, it was not found to be effective in preventing community-acquired pneumonia from any cause, naturally. There were limitations to this study. There was no comparative group that received pneumococcal polysaccharide vaccine. It was a placebo-controlled trial, and hence it's doubtful if PCV13 actually provided better protection. The trial specifically excluded subjects who were regarded as immunocompromised, and even the few subjects who developed immunocompromise during the trial period were not shown to have a protective effect from pneumococcal conjugate vaccine, though their numbers were too small to be statistically significant. And importantly, the trial began before PCV13 was routinely introduced as an immunization for infants in the Netherlands. And so it's doubtful whether herd immunity would affect the efficacy in adults in the long run. And apart from herd immunity that we just discussed in this trial, the other interesting phenomena is the replacement strain phenomena that we have seen with the pneumococcal vaccines. So you can see in the pictorial here that the PCV7 was introduced in the United States in 2007. And thereafter, you can see the widespread use of the conjugate vaccine led to emergence of the non-vaccine type serotypes that have appeared as colonizers of the nasopharynx and hence as a cause of pneumonia. This is in children under the age of 5, and this picture below here is in adults over the age of 65, showing you that the pneumococcal vaccine serotypes have reduced dramatically, but the non-serotype group has increased. This reduction in nasal carriage of PCV serotypes appears to create an ecological niche for the non-vaccine serotypes. And as an example of this 19A serotype, which was not included in PCV7, actually emerged as the most common cause of pneumococcal disease in children and adults a few years after universal vaccination began in the United States. And so let's move on to, now that we've understood the two concepts of herd immunity and replacement strains, let's move on to what actually happened over the past few years in the United States. So once again, PCV7 introduced in children in the year 2000. PCV13 introduced in children in the year 2010. And PCV13 introduced as part of the routine immunization in all adults over the age of 65. And what did they find? So you can see from this graph over here that the incidence of the PCV type disease reduced to historically low levels among adults aged more than 65 years, even before it was introduced into the immunization program for adults. So this is clearly through indirect effects from pediatric PCV use. Additionally, implementation of the PCV13 recommendation for all adults more than 65 in the year 2014 had a minimal impact on the disease at the population level in this age group after 2014. And so what did this eventually result in? The Advisory Committee for Immunization Practices from the CDC actually did a little flip-flop in their guidelines in 2021, where they have removed PCV13 from being routinely recommended in adults over the age of 65, as well as adults over the age of 65 who are immunocompetent but have at-risk factors for pneumococcal disease, like diabetes or chronic organ dysfunction. And they've actually introduced this concept of a shared clinical decision-making, which I will discuss a little later. The other recommendations remain pretty much the same, but these have clearly been changed. They still recommend the pneumococcal polysaccharide vaccine if it hasn't been taken in the last 5 years in all adults over the age of 65, but not the pneumococcal conjugate vaccine. And the reason for that is the herd immunity created by the pediatric vaccine, which doesn't seem to afford any further benefit by vaccinating these adults. So if I can come back to my case just once more. If you recall, this patient was a rheumatoid arthritis case on rituximab. I want to ask you, which infections does rituximab predispose to? The ones present in A, hepatitis B, TB, pneumocystis jirovecii, JCV, CMV, encapsulated bacteria, or TB, pneumocystis, toxoplasma, cryptosporidium, mycobacterium avium, strep pneumonia, or C, aspergillus, TB, BK virus, CMV, nocardia, cryptococcus. Why is it important to understand this? So rituximab actually predisposes to the conglomerate of infections in A. And why is that? Because it produces prolonged B cell dysfunction for about 12 months after the injection. It produces hypogammaglobulinemia, a late onset neutropenia after about 4 weeks, impaired BT crosstalk, which means sort of changes in the cellular and humoral immunity as well, and reduced response to vaccination. Again, why are we discussing this over here? Because we need to understand that our at-risk population, our immunosuppressed population, is dynamic. It's changing, it's evolving. As more and more people are exposed to healthcare, to different monoclonal antibodies, biologicals, we're going to have to understand and appreciate the predisposition to different organisms and incorporate these predispositions when we sort of think about our vaccine strategies. So let's discuss a little more about the predisposing factors for strep pneumonia. And the immunocompromised group is really quite straightforward. You have the sickle cells, the hemoglobinopathies, you have congenital and acquired dysplasias, you have chronic renal failure and nephrotic syndrome, which is an important group, congenital and acquired immunodeficiencies, HIV, which unlike the other opportunistic infections which have dramatically reduced with the onset of heart, strangely for pneumococcal pneumonia, the incidence still remains quite significant in the HIV population and especially in the untreated advanced AIDS population. Malignancies, hematological malignancies, organ transplant and iatrogenic immunosuppression like that which was discussed in the case before are all very important factors. This is an important group, the immunocompetent adults, but those who are at risk. Okay, this is seemingly more than 50 or 75% of our adult consultation practice. The diabetics, chronic organ dysfunction, cigarette smokers, alcoholism, cochlear implant and CSF leak are very specific risk factors, but they put immunocompetent adults also at risk. However, this sort of this group of risk factors is not in keeping with a classic immunocompromised state, and yet it produces a subtle sort of immunocompromise that is important and that predisposes these individuals to pneumococcal infection. The shared clinical decision making that the ACIP body talks about takes into consideration adults, especially elderly adults who reside in nursing homes or other long-term care facilities where there may be greater opportunity for pneumococcal carriage and infection. Those who are residing in areas or regions with low pediatric PCV uptake, or those traveling to countries where there is low or no pediatric PCV-13 program. So this study actually went on to prove how important these high-risk groups are for pneumococcal infection. And it looked at increased risk of pneumococcal disease associated with established risk factors which have persisted in the era of widespread vaccination. So where herd immunity has not really helped in these groups of patients. So there are increased rates of pneumococcal disease among persons with more than one at-risk condition as per this study, and extremely high rates in those with more than 3 at-risk conditions, making younger adults with at-risk conditions sort of develop pneumonia, all-cause pneumonia at a rate of 15.6 times that of healthy persons. So this phenomena of risk stacking actually was very well highlighted in this study, whereby the risk of disease increases with an increasing number of risk factors. And you can see that here. This is in pneumococcal pneumonia, the upper graph, and the lower one is in those with IPD. And you can see as per the different age groups, 18 to 49, 50 to 64, and more than 65, how the incidence of pneumococcal pneumonia or IPD increase as the number of risk factors increase. And so we're left with little doubt that these risk factors are important and they go a long way in preventing pneumococcal disease in the at-risk populations. However, we must remember that for on a global sort of public health perspective, it's very important for us to understand the global disease burden in order to satisfy the need for a vaccine and sustain its continuous rollout. So the pneumococcal global disease burden, if we may describe it, we know that lower respiratory tract infections are defined as either pneumonia or bronchiolitis are the leading cause of death globally. Strep pneumonia has emerged as the leading cause of morbidity and mortality, contributing to more deaths compared to all other etiologies combined, and this was data from 2016. And the WHO estimates that strep pneumonia kills close to 500,000 children under the age of 5 worldwide every year. Most of these deaths, unfortunately, occur in developing countries. Does that apply to us here in India? Very much so. And this surveillance study, estimate surveillance study, which was published in Lancet Global Health in 2018, goes on to point exactly this out, that you can see the largest circle on India. Approximately 50% of all pneumococcal deaths in 2015 occurred in 4 countries in Africa and Asia, of which India had the largest number of deaths, 68,700, followed by countries like Nigeria, DRC, and Pakistan. This graph actually, in the same study, showed us how, as a proportion of children who were not immunized with PCV reduced, this was directly proportional to a reduction in deaths due to pneumococcal disease. So pneumococcal disease deaths in 2015 reflected a 51% decline compared to 2000. Okay, despite the fact that vaccine rollouts hadn't happened in most of these countries. And pneumococcal deaths in children infected with HIV also declined from 75% in 2000. Of all the pneumococcal deaths, pneumonia accounted for 81%, meningitis for 12%, and non-pneumococcal non-meningitis for just about 7%. Important to remember and understand that among the 4 countries with the highest pneumococcal burden, India, being the largest pneumococcal burden, was the last to implement routine use of PCV in 3 states as late as 2017. And so despite a 58, so this was a study that was done after that by the same authors, published in 2019, which looked at a sub-national level estimate of the national, regional and state level burden of strep and Hib in children in India. And it showed that despite 58% reduction in the pneumococcal deaths, it still accounted for 14% of all deaths among children. 75% of pneumococcal deaths in 2015 occurred in the 8 empowered action group states as well as Assam. When we talk about the empowered action group states, we're talking about the central states of Rajasthan, Uttar Pradesh, Madhya Pradesh, Chhattisgarh, Odisha, Bihar, and Uttarakhand. And how come we had this 58% reduction in pneumococcal deaths? What is to account for this? Well, the authors of this study actually feel it was because it sort of reflected improving sort of trends in childhood mortality. It was also perhaps attributable to the National Health Mission, also called the National Rural Health Mission, which was launched at that time in 2005, which probably did its bit in reducing childhood mortality. But despite this, you can see that there was still a large burden of pneumococcal disease, especially in these states. So what was the scope of pneumococcal vaccine in India? We know that most deaths from pneumonia in India, in our country, unfortunately occur in the community, indicating that most people probably do not even have access to antibiotics. Although PCV was introduced in the private sector in 2012, the estimated overall national coverage was reported to be lower than 1%, and this was not even taken into consideration when they considered why the trends were reducing before introducing the vaccines. This IPD surveillance study in 2011 and 2015 in India showed that the 13-valent serotypes were responsible for approximately 74% of invasive pneumococcal disease nationwide. And this is a graph here. Before I go ahead, this is a graph here showing you exactly the same thing and what led to a marked shift in the policy of vaccination for the first time with pneumococcal vaccines in India. So earlier, when vaccines were launched into the universal immunization program in the country, they were launched based on the states that had the most robust and efficient health systems. However, based on this study, there was an opportunity for evidence-based shift in the approach of PCV introduction, which was introduced into the states prioritized on the basis of mortality. And so the states that had the highest burden of disease and the highest mortality, the vaccine was actually rolled out into these states the first. And this was done by the National Health Mission, by the Ministry of Health in 2017, under the Universal Immunization Program in selected states of Himachal and parts of Bihar and Uttar Pradesh. In 2018, they expanded this to Madhya Pradesh and Rajasthan, and then they plan to roll it out into the other states in a phased manner. Gavi will sponsor the immunization and provide for it until 2021, and we'll discuss a little later what happens after 2021. So I don't want to go too much into the detail of pediatric immunization, but suffice to say that we can't discuss adult immunization in pneumococcal vaccines without understanding what's happening at a population level in pediatrics, because so much is related to the indirect effects and herd immunity. This schedule is by the Ministry of Health, and it differs a little bit from the Indian Academy of Pediatrics schedule. But basically, there are multiple doses of pneumococcal conjugate vaccine given before the age of 2, followed by a single dose of polysaccharide given after the age of 2. So let's look at where we stand with the adult population in India. And there are a few studies, albeit small studies. This is an 11-year experience from CMC Vellore, which looked at 402 patients. It was a little discouraging because the vaccine serotype coverage for the currently available vaccines was abysmal. Well, I can't say abysmal, but certainly reduced and less than what it was in the earlier studies. So for PCV13, it was about 58.7%. For pneumococcal polysaccharide vaccine, it was about 68%. And there was definitely an increasing antimicrobial resistance trend in the pneumococcal meningitis isolates. Penicillin resistance was to the tune of 28% and cefotaxime resistance almost 10%, indicating a need for a change in antibiotic policy, especially in the invasive pneumococcal disease or pneumococcal meningitis group. Another study from Kerala, much smaller study in about 55 patients, of which only 39 samples were serotyped, but here more encouraging data showing us that the coverage of pneumococcal isolates by the vaccine was about 70% for PCV10, 80% for PCV13, and 97% for polysaccharide vaccine 23. And so if we move ahead to the adult pneumococcal immunization recommendations in India, we have to understand that there are multiple heterogeneous groups that make recommendations from time to time. Unfortunately, they're not updated with any regularity. And so there are multiple such groups: the Association of Physicians of India, Expert Panel, Research Society of Diabetes, Indian Society of Nephrology, IMA, the Geriatric Society of India guidelines, I've different from each other. Stark difference is the stand that the Association of Physicians of India has taken in this 2000 immunize all those under the age of 50 and not 65. I'm not certain for the rationale of this, but this is how it stands. So these are adults under the age of 65 with risk factors. And in all the other sort of groups or the other guidelines, the recommendation remains more or less the same. The IMA has incorporated this under 50 and over 50 of the API, but otherwise recommendations remain the same. That is 1 dose of PCV13 to any young adult who is at risk or anybody above the age of 50 or 65 with risk factors, followed by pneumococcal polysaccharide vaccine. Booster doses would be required in population under 65, no booster doses of the polysaccharide vaccine in patients above the age of 65. And all these guidelines are sort of explained in these references. Important to note that the Indian Consensus 2019 guideline has actually explained why we're not going to follow the ACIP 2021 recommendation of doing away with PCV13 routinely for all adults over the age of 65. And that's clearly because the immunization with the pneumococcal conjugate vaccines was introduced into the pediatric population in the United States in 2000 and 2013. And the herd immunity that can be expected in their adult population has been proven in their adult population cannot be expected from our population because our pediatric immunization program has just begun rolling out in 2017 in select states. And so we can't expect the same degree of herd immunity, and perhaps we should continue vaccinating our at-risk adults or our adults over a certain age with PCV13. So what are the strategies that lie ahead? And as I explained earlier, Gavi is going to sponsor our universal immunization program of PCV13 until 2021. What happens after this? The Serum Institute of India has recently launched the first fully indigenously developed pneumococcal vaccine known as Pneumosil. It is a pneumococcal conjugate vaccine with 10 serotypes. The reason for introducing this is that it has a far more affordable competitive price as compared to Prevnar. The WHO has approved it for both invasive pneumococcal diseases, pneumonia, as well as otitis media for children under the age of 2. It's specially tailored as per the prevalence of the top 10 serotypes in India as well as other regions of the world. And it has the advantage of serotype 6A and 19A in the vaccine, which are responsible for a great deal of global sort of disease burden. Phase 1 and 2 studies done in Gambia have been released, and you can see that this was no more a placebo-controlled trial because now we have comparator vaccines. So this vaccine was compared to the PCV13, and seroprotection rates of more than 90% for all serotypes were seen with both vaccines, except for serotype 6A and 6B, which were poor with the PCV10 or the Serum Institute vaccine. The immunogenicity of the pneumococcal vaccine is measured by the opsonophagocytic activity. That's a tongue twister for me. And this is an assay that is measured. It basically measures the opsonophagocytic capacity of the antibodies against the of the antigens, the virus antibodies against the pneumococcal antigens, and it measures them by the basis of this geometric mean titer. So the OPA GMT, to make it simple, following the primary series, were comparable for the two vaccines for 6 and 10 serotypes. A significant booster response was noted with both the vaccines when primed at 6, 10 and 14 weeks. And again, the OPA GMT following the booster vaccine in toddlers was generally comparable with both the vaccines. And so this has been approved, and phase 3 trial data is shortly awaited. In addition, very recently, just in June 2021, the US FDA has approved Prevnar's pneumococcal 20-valent conjugate vaccine, or Prevnar Pfizer's 20-valent pneumococcal conjugate vaccine, or Prevnar 20, for adults aged 18 years or older. This vaccine also contains capsulopolysaccharides for 7 additional serotypes, which have been associated with high case fatality rates, antibiotic resistance, and/or invasive pneumococcal disease and meningitis. They account for approximately 40% of all pneumococcal disease cases and deaths. And the preliminary data from almost 4,000 participants in the phase 3 trial shows non-inferiority in immunogenicity in adults over the age of 65 when it was compared to PCV 13 followed by PPSV 23, which is the current guidance. So clearly this is something that we understand is an evolving guideline and will probably replace the current recommendations of PCV 13 followed by PPSV 23. So that's what we have in the current and near future. And if I can summarize my talk, there is no doubt that India has a very significant pneumococcal disease burden even now, and herd immunity is still unlikely because the pediatric immunization program is still in its nascency with regards to pneumococcal vaccines. There's a growing population of high risk and at risk adults, as shown in the case that I highlighted, and so as physicians, as adult physicians, we need to have a lower threshold and a protocolized system for vaccinating these patients before we put them on immunosuppression or recognize other conditions that may put them at risk. There are dynamic changes in serotypes, in the antimicrobial resistance, which needs to be revisited with larger epidemiological studies done from time to time, on the basis of which we can make unifying evidence-based recommendations for adult immunization, especially for developing countries like ours. So thank you, and with that I'll end my talk and take any questions if we have time.
I think the chairpersons are sort of missing, so I will just butt in. Aisha, there's one question. The API recommends 2 doses of PPSV, but other organizations recommend 1 booster dose. What would you advise?
So the API recommendation is just for 2 doses. They haven't really explained whether they mean this is a booster or not. I wasn't able to find that explanation. But clearly, under the age of 65, booster doses have been recommended by international guidances as well, between 5 to 7 years. Above the age of 65, no boosters recommended for the pneumococcal polysaccharide vaccine.
And Vartika Agarwal would like to know, what is the schedule for adults? She's not mentioned any comorbidities. She's just asked, what is the schedule for adults? So would you like to take that?
So would you like me to go back to that slide? So there's a slide where I've actually tried to summarize the different groups that have come up with adult vaccination schedules in the country. However, if I was to sort of briefly state, there is no recommendation for adults under the age of 65 who are healthy and immunocompetent for pneumococcal vaccination. Those adults who are at risk or have any other immunocompromised state need to receive 1 dose of pneumococcal conjugate vaccine, or your Prevnar 13, followed by the pneumococcal polysaccharide vaccine, either a year later or at least 8 weeks apart, depending on the risk factors. And this would apply as well to adults over the age of 65 who would receive, to begin with, a pneumococcal conjugate vaccine, like the Prevnar 13, followed by the pneumococcal polysaccharide vaccine if they haven't received it earlier or in the last 5 years, as a single dose, again with a gap of minimum of 8 weeks and ideally of about 1 year.
I think we are running out of time, so thank you very much for the talk, Aisha. I'm going to hand over to Darshini now to welcome and introduce the next speaker. Thank you, Aisha.
Thank you.
Over to you, Darshini.
Yes, sir. So the next topic will be on influenza vaccine in COVID times by Dr. Vinay Devraj. So Dr. Vinay Devraj, he is medicine and F&B ID infectious specialist, Apollo Hospitals, Bangalore. We warmly welcome you, sir, for the next topic.
Thank you. I hope my slides are visible. Just a thumbs up would do if it's visible.
Yes, Vinay, you can proceed.
Thank you, sir. Right. So, right. At the outset, I'd like to thank SITS and the API Tamil Nadu Charter for creating this platform to discuss adult immunization, which we know by now is the need of the hour. My topic for today is influenza vaccination. I'll discuss the broader perspective of influenza vaccination and then come down specifically to discuss the role of influenza vaccine in this COVID era. Ubiquitous and a cosmopolitan disease which is existent with humankind for a long time. Influenza has long been recognized as a major threat to global health, and it was officially documented so by the World Health Organization in the year 2019 as well. A disease of aquatic origin, courtesy multiple genetic changes, antigen variations, it has turned out to be pathogenic to many animal species, including humans. Of the 4 types of influenza which we see in nature, influenza A and B are the ones which are by and large pathogenic to humans. The A variant has numerous antigenic combinations and resulting in various subtypes, whereas the influenza B has 2 lineages called Victoria and Yamagata. So based on these genetic changes in the antigenic structure, when the antigens combine, undergo reassortment, and if there are some minor changes and mutation, influenza undergoes what is called as an antigenic drift. Antigenic drift is what is by and large responsible for seasonal outbreaks, whereas if major changes do happen and the entire genetic structure does get changed over and a new variant of the influenza virus occurs, it's called as antigenic shift. Antigenic shift is what is by and large responsible for major epidemics and huge pandemics. If we discuss about pandemic as a long-running web series, trust me, influenza has had the major and maximum recurring role in various forms. And in the last 500 years or so, influenza is one infectious disease which has killed more than any other. This is even now, clearly and robustly documented by the US CDC, wherein with a good reporting system, it shows there is consistent number of cases of influenza-related hospitalization and deaths reported all across US. Even with a good reporting system, it is very clear, and it is also accepted by the CDC and World Health Organization, these numbers may not essentially be real and true. For the reason that all these depend on the laboratory confirmed cases of influenza, and we know that diagnosis of influenza with a clear-cut laboratory confirmation is not always forthcoming. So the WHO clearly says, even though there are projected numbers in its own surveillance network as well, we may be underreporting influenza all through the world. Beyond the actual figures and numbers, there may be in totality of 1 billion cases of influenza all through the world per year, of which 6.5 lakh deaths may be occurring annually. This seems to be true, that underreporting may be a real issue when you look at the Indian numbers. So even with a good reporting system that is in place with an integrated surveillance network in India, the numbers don't really seem to match that of the US at all. They seem to be grossly underreported, which is also proven by many of statistical analysis, which project that the numbers in India, Indian subcontinent and Asia are by and large less, and the numbers may be actually more as the age progresses. These studies also reiterate the fact that many deaths do happen under the age of 5, but more deaths also happen after the age of 65 as well. One of the latest study, which was a good statistical analysis taking into account the excessive mortality which may occur due to influenza and influenza-like condition, clearly shows that the official figures that are projected by the NCDC, which is responsible for the reporting system and numbers of influenza in India and many other infectious diseases, may actually be very, very less, and a good number of influenza cases and influenza-related deaths may be missed. It's not just the number and death. Influenza is a disease of huge socio-economic impact and burden. Influenza is a disease which is listed as a disease of high mortality, high incidence, and also it takes away a lot of quality days because of the illness that it causes. So for this reason, influenza is of vital importance in the current day infectious disease scenario. It's a disease with multi-system involvement. Though starts off as a respiratory illness, it's a disease with multi-system illness and causes numerous complications, which may be neurological, cardiac, respiratory, and also it's known to cause complications in pregnancy. Though it's a disease of major concern, causing a lot of morbidity and mortality, the good thing is influenza is preventable. It's a vaccine preventable disease, and we do have a good vaccine to overcome that. What are the types of influenza vaccines which are available? those which are there currently in market are divided based on whatever is used as the antigenic component. So we have the live attenuated virus, as for many other vaccines, wherein the entire genome of the virus is used to induce immunity in humans. There are the vaccines which are killed and inactivated, which do not induce robust immune response like the live attenuated one, but still do their job. Among these, the subunit vaccines and the split virus vaccines, which are both killed inactivated, are available commercially. Among the latter two, if you compare, the split virus vaccines have had greater benefit, greater safety and tolerability, and hence are widely used. If you have a one-on-one comparison of the killed inactivated vaccine with the live attenuated virus vaccine, theoretically speaking, the live virus vaccine should be of greater benefit because the immunogenicity or immune response that it induces is intense, is long-term with good immunological memory. But in practice, on ground, data has clearly indicated that it has not shown consistent benefit across all age groups. And paradoxically, it is the killed inactivated virus vaccines which have done the job more effectively than the live virus vaccine. Another major drawback with the live attenuated viral vaccine is that it is not usable in those high-risk groups which essentially need the influenza vaccine, including pregnancy and the immunocompromised. So the killed inactivated vaccines have found greater benefit, and they are widely used. Now, what is the composition of the virus vaccine? What is the composition of influenza vaccine? It completely depends on what are the prevailing serotypes of the vaccine, which are there all through the world. The Working Committee of World Health Organization sits twice a year. Based on its global surveillance network, it assesses what are the common types of influenza which are prevalent in a given season. It divides the globe into Northern Hemisphere and Southern Hemisphere. And depending on the prevalent vaccine types, it proposes a quadrivalent vaccine, which has 2 influenza A, the most prevalent one for that season, or 2 influenza B. Or it also proposes a trivalent vaccine, which has 2A and 1B. So what is more beneficial, the quadrivalent or the trivalent? Numerous studies of late have clearly indicated the benefit of the quadrivalent vaccines more than the trivalent vaccines because the incidence of influenza B is clearly on the rise, and influenza B can cause as bad a disease as influenza A. So even the guidelines from the Indian Chest Society and National College of Chest Physicians, which proposed the clinical practice guidelines in 2019, clearly favors or errs towards the side of the quadrivalent vaccine. So when do you vaccinate? What would be the best time to vaccinate? Like I mentioned, WHO divides it into Southern Hemisphere and Northern Hemisphere, and then India is classified in the Southern Hemispheric zone. The World Health Organization says April is a good time to vaccinate. But there is no clear consensus when it comes to the Indian guidelines. It divides various zones based on when the influenza outbreak happens. And it has suggested that April to May for some and September to October for another. But if you clearly look at the global surveillance network data, it is pretty clear that the activity of influenza is present all through the year, with peak surges which happen pre-summer, February to April, and then pre-monsoon or during monsoon, July to August. So it goes to say, based on common logic and understanding, that any time of the year is a good time to vaccinate. This is what most of us do when it comes to infectious disease practice. Also, given the fact that the availability of vaccine is always in question. So this we have experienced in the last 2 to 3 years. Influenza vaccine may not always be available. So any time of the year when the patient is in front of you, particularly the high-risk group, please vaccinate and do not wait for an ideal time. It's an effective vaccine without doubt. The effectiveness is highly proven. When I talk about effectiveness, this is the ground level effectiveness, wherein you're given it and the patient is in, not in the laboratory, but is in population at large. And influenza has been by and large proved to be very effective. The age group which has maximum benefit is childhood, of course, but adults do have a lot of benefit as well. It is not merely restricted to number or percentage. It is based on the 2 important words which we are trying to hear for the last 1 year: herd immunity. Influenza is one of the important vaccine if you cover the vulnerable group well, and if you cover the healthy group as well, it induces herd immunity and then protects the high-risk group in a great extent, and this has been clearly proven beyond doubt. Influenza has been historically known to be a vaccine which has a lot of adverse effects. At least this was what was reported previously. The major concerns were neurological, including Guillain-Barré syndrome and anaphylaxis. But over the last 20 to 25 years, more and more studies have emerged and have clearly documented that influenza vaccine-related side effects or adverse effects are more or less theoretical than they are on ground level. This good sentinel network analysis from UK clearly depicted the side effects, neurological or hypersensitivity and anaphylaxis, is much more with the disease itself than with the vaccination per se. So it clearly indicates that the vaccination is by and large safe. Other major concern when it comes to influenza vaccine, which has always been in most of people's mind, is anaphylaxis, because there were previously reported episodes of anaphylaxis because of the egg-containing vaccines. Does someone who has egg allergy, is it safe for him to take the influenza vaccine? So in the year 2018, CDC has finally once for all answered the question, and it is clearly mentioned, even if you have an egg allergy or any other sort of allergy, if the allergy is minor, do not worry, please go ahead and take the influenza vaccine, because the only true contraindication for influenza vaccine is any major anaphylaxis episode if you are ever experienced with life. This logic is what has been extrapolated to COVID vaccines also now, because you have never taken COVID vaccine. You may be a vegetarian and not had egg before, and you won't know whether you have egg allergy or not. So the simple common sense based logic is that if you're not had any major anaphylaxis to anything, go ahead, safely take the influenza vaccine. So in summary, if you have to talk about the influenza vaccine as such, it is a safe, effective, tolerable vaccine which has great effectiveness, particularly when it comes to the high-risk groups, and any time of the year is a good time to vaccinate. Focus particularly on the high-risk group is the message. So what are these high-risk groups? In general, the general understanding is that anybody with chronic end-organ disease, particularly of liver, kidney, heart, and in particular of the lung, are the essential candidates for influenza vaccine. Apart from this chronic end-organ diseases, anybody with immunocompromise of any form, either disease or drug-induced, pregnancy and diabetes are believed to be the major high-risk groups. This was well documented by the global pooled analysis, which was done after the 2009 influenza pandemic, which clearly showed that the major risk factors, including age, were documented. Here, the graph which plots the age versus mortality clearly says that the risk of hospitalization is highest, as shown in the blue graph, in the younger age group. The risk of ICU admission is more in the extremes of age group, and the risk of death, as projected in the red graph, increases directly proportional to the age. The other high-risk groups, which we previously know, also was documented in this pooled analysis, which clearly showed that anybody with a chronic end-organ disease of any sort is at a higher risk for influenza, influenza disease, influenza-related complications, and also death. Pregnancy was in a variable zone wherein the risk is definitely high, but the risk of death, mortality is higher in the third trimester of pregnancy. So I would just go through a few of the studies which show how some of the risk groups can be benefited or protected from influenza vaccine, one of which is coronary vascular disease, wherein the studies have clearly documented that influenza increases the risk of myocardial infarction and also of death by the virtue of disease itself. And the vaccine has clearly documented to show that it reduces the incidence of influenza, and consequently, it reduces the incidence of influenza-related MI or death in individuals with coronary vascular disease. By sheer numbers, the biggest risk group for influenza-related worsening are the ones with chronic lung disease. It is clearly documented beyond doubt in many studies that respiratory viruses are the major reasons why acute exacerbations happen in chronic lung disease, and influenza tops the list, as is documented in many of the studies which are projected here. It is also clearly documented if you give timely annual influenza vaccination, the side effects of chronic lung disease, acute exacerbation episodes of chronic lung disease, hospitalization and death due to chronic lung disease is clearly reduced virtue of influenza vaccination. And this is true for all spectrum of chronic lung disease, mild to severe. It is also clearly documented if you club annual influenza vaccination with the pneumococcal vaccine, the rate of mortality significantly drops down by 81%. So if you target elderly and those with chronic lung disease, if you club these two vaccines, there is a greater benefit, which is clearly documented. Two of the most underappreciated, under-recognized risk groups for influenza-related complications are diabetes. It is clearly known that people with diabetes mellitus across all control range are at higher risk of lower respiratory tract infection, particularly with influenza and pneumococcus. Pregnancy is a high-risk group for influenza, wherein the risk of maternal mortality, ICU stay, prematurity, and IUGR is greater, and hence the need to vaccinate pregnant women with influenza every year. This should be done. Since there is a separate topic on healthcare worker vaccination, I would not go into much detail, but I would like to highlight with few slides that influenza has a great role in not just protecting the healthcare worker, influenza vaccine rather, it also protects the patients who are managed by these healthcare workers, as was seen in this study from Scotland, which clearly showed that those hospitals or healthcare networks which had a robust annual influenza vaccine network program did have a lower number of deaths in patients compared to those wherein the healthcare workers were not regularly immunized. This study clearly showed the benefit of influenza vaccine in reducing the absenteeism in healthcare workers if they are vaccinated every year. So there were 3 groups which are shown here. One of the group which took influenza vaccine every year before the onset of influenza season. This group which took the influenza vaccine but after the onset of influenza season, and the third group which did not take vaccination but agreed to have a regulated and mandated mask policy. That is, they wore mask always when they were in the hospital. Now, in spite of this, what you see here, in spite of them wearing masks all the time, they still did have a lot of episodes of influenza and lost a lot of hours due to influenza illness, and vaccine clearly showed benefit. The benefit is maximum in the emergency department, who are the frontline workers who get exposed to the influenza cases first, and also the severe variants of influenza. Remember, this study was conducted much before the mandated mask policy that we have right now. So these workers, these healthcare workers are at highest risk of getting influenza, and this study clearly showed that if you vaccinate them annually, the risk of illness and severe disease is significantly less. So if you go by this data and understand that there are a lot of high-risk groups for influenza, where the risk is high, risk of hospitalization and death is high, and if you vaccinate them regularly, identifying them, you really reduce the risk of influenza-related mortality. So if you also understand COVID is another disease where these high-risk groups have a greater incidence of COVID. So be it coronary vascular disease, chronic lung disease, pregnancy, diabetes, these are the high-risk groups for COVID. So by that logic and understanding, it makes it quite obvious that influenza is a disease of great concern in COVID. It is clearly and objectively documented by many studies. These studies which came about in the early phase of pandemic also showed influenza was one of the most common disease to be associated as a co-infection with COVID, and also a disease wherein if it is co-infected with COVID, caused a lot of ICU stays and mortality. So even later studies which have come out this year have clearly documented that common co-infections that exist along with influenza, the respiratory viruses, particularly respiratory syncytial virus and influenza, top the list. And in this group, there is a greater chance of superinfection following ICU stay and greater chance of prolonged ICU stay and mortality. If you remember, one of the complications which is noticed with influenza is the post-influenza pneumonia. Among this, pneumococcal pneumonia, MRSA pneumonia, and gram-negative pneumonias, particularly Pseudomonas, top the list. So if influenza co-infection does happen with COVID, it is clearly documented there are more superinfections, and more the superinfections, more the mortality in such patients. So clearly influenza is a disease which causes greater mortality in individuals with COVID, and it is clearly documented in many studies. Now, other thing which data is yet to emerge, but I'm sure will come out, is COVID at the end of the day, be it moderate or severe disease, pushes the individuals who have recovered into some sort of chronic lung disease status. So when we talk about chronic lung disease, what is documented here is fibrosis, which is seen in many individuals who have recovered from COVID. You can count them as one of the groups of chronic lung disease. And when it comes to chronic lung disease, we know for sure influenza is one of the common trigger for worsening of COVID lung disease. So we have to consider COVID as a priority disease, a high-risk disease, where influenza incidence is high and it may cause complications. So we have to vaccinate these individuals as well without fail. So CDC has come out with clear-cut guidelines as to vaccinate these. It agrees to the belief that, yes, you have to vaccinate these individuals without doubt. But how do we go about and how do we choose them? So it is simplified, but with certain markers. Any individual who is a primary contact of someone with documented COVID but does not have any symptom, vaccinate. Any individual who has COVID but does not have symptom as of now, vaccinate. But any individual who has COVID but has symptoms, wait till the symptoms resolve. So if you have to go by this recommendation from CDC, you need to understand that anybody with influenza, anybody with COVID rather, has to be immediately vaccinated with influenza vaccine. But the practice, what we follow most often, at least what I do in clinical practice, is once they recover, I do call them back after 2 weeks, which is essential for a follow-up, and vaccinate them 2 weeks after recovery, because they are mentally and physically well prepared to accept the vaccination, but do make it a mandated habit to vaccinate these set of individuals. Now, other end of this argument, I'll finish in few slides. Other end of this argument is that courtesy, good infection control measures, less cases of influenza has been documented. See this in the last phase of 2020 and 2021, very few cases of influenza have been documented in the global surveillance network. This is believed by and large due to the constant effort by the government and more so by the media, which has induced such sort of fear psychosis and enhanced infection control measures. People are taking care of themselves, masking, so probably the influenza incidence has come down. But please do remember, at the end of the day, we are all humans, waiting in a lockdownish behavior, waiting to break out. And once that happens, influenza cannot be ignored anymore and will go back to the same status wherein influenza will increase and will increase in the high-risk groups. So all of us need to be vaccinated. So remember, getting back to this slide, which I showed, these individuals did wear a mask, the healthcare workers, even then, they did have a higher incidence of influenza. So it's not just about masks, particularly when it comes to healthcare workers and other high-risk groups. Please propagate the role of influenza vaccine in preventing disease and death. So I would follow more of CDC guideline than WHO. Anybody above the age of 6 months, when the vaccine is available, should be vaccinated. And influenza vaccine goes a long way in preventing a lot of complications in COVID and other high-risk groups. So even though my background might suggest otherwise, but webinars have been a good source of knowledge dissemination and sharing. So thanks being part of this endeavor, and I'd be happy to take any questions. Thank you.
Darshini, you want to take on a few questions for it's in the chat box. Would you like to ask Dr. Vinay?
Yes, sir. Sir, one question in the chat box is, how early after an acute exacerbation of COPD can you give the influenza vaccine and pneumococcal vaccine? Can it be given on discharge itself?
That is what we do. Yeah. So I think it's not a contraindication as such. So one of the drawback of vaccinating an individual when he has an active phase of disease is he may not mount an immune response. But if you have treated someone with acute exacerbation of COPD or some other respiratory disease and the individual is recovered, discharge is the right time to vaccinate, because like I mentioned while discussing, they are mentally more prepared when they are better. But when it comes to COVID, they are not physically still ready. Maybe their immune response is not so good. So I would wait for 2 weeks. When it comes to lung diseases, I would vaccinate them at discharge when they are clinically stable.
Yes, sir. One more question. What is the ideal time to vaccinate pregnant women? Any specific trimester, sir?
Though the guidelines initially recommended third trimester would be better, or at onset of third trimester would be better, what we do understand is any time of pregnancy should be a good time. And particularly when the pregnant woman comes for the first health check, please do go ahead and vaccinate, because the pregnancy is a high risk zone for influenza in all the trimesters, though the complication is more in third trimester. So we are not trying to just protect the child, we are also trying to protect the mother. So any time when the mother comes in for checkup, please do vaccinate, don't wait for any particular trimester.
One more question, sir. Which one recommends, sir, trivalent or quadrivalent influenza vaccine? Anything
right.
Specific? This is
So like I said, I think it's a matter of choice more than a real guideline oriented approach. So what I would say is, if you have a quadrivalent vaccine available, err on the side of using a quadrivalent vaccine, because even in India, more and more of influenza B related cases have been reported. But if your center does not have a quadrivalent vaccine, but the trivalent vaccine is readily available, do not wait for a quadrivalent vaccine to come. If you have both, which rarely happens, it is quadrivalent. If you have either of them, go with either of them. The choice is obvious.
Thank you so much, sir. Shall we move on to the next topic, sir?
Yep.
Yes, sir. So the next topic will be setting up an adult vaccination clinic. I take great pleasure in introducing Dr. V. Ramasubramanian, sir. He is the director of the Capstone Clinic and also the consultant infectious disease and tropical medicine department, Apollo Hospitals, Chennai. He is also an adjunct professor, infectious disease, Sri Ramachandra Medical College, and also the Tamil Nadu Dr. MGR Medical University. We warmly welcome you for this topic, sir.
Thank you very much, Dr. Darshini. It's been a real pleasure, being here this evening and listening to excellent lectures. I think, Vinay, that was a very, very nice practical session. And the reason for this talk is only to encourage that more people get vaccinated. And this slide, this photo very clearly illustrates the current perception or the current feelings or sentiments which people have. The children are very happy to get vaccinated. But when you look at the adults, they are the ones who are actually feeling bad or pained or whatever in this situation. So the first question is, why do adults need vaccinations? I think in the introductory talk, we discussed about it and said that we need vaccinations because we need to ensure that our immune system is recharged. We have seen that with COVID very clearly that in spite of your initial schedule, you probably need more boosters as you go along. It may be due to the occurrence of comorbidities, which you develop as you grow older, diabetes, high blood pressure, heart disease, or lung disease. It could be due to the fact that there are certain diseases which are at an increased risk to happen, depending on certain occupations, depending on certain lifestyles. So for all these reasons, we know that adults need vaccinations to prevent several vaccine preventable diseases which can happen predominantly in adults. But unfortunately, the current scenario is like that. People are, in fact, one of my colleagues had said a few years ago that if you go to the Google and look at adult vaccination in India, you'll find adults vaccinating children rather than them taking vaccines. And thankfully, this was over a decade ago. Things have changed. The concept of adult vaccination and the importance of vaccinating adults has picked up very nicely. But still, if you need a vaccine, there are very few places a patient can go to access a vaccine. I'll give you an example. Right now, the situations where people need vaccines are if they are children who are about 20, 22, 23 going abroad for postgraduate studies. These are 22, 23-year-olds after finishing their engineering college or going for PhD or other post-graduation. And most universities in US and UK and Australia mandate the measles vaccine. They may also stress on the uptake of flu or hepatitis B vaccines. And it is very difficult for these adults to get vaccines because most vaccines, as Dr. Muruganathan said earlier, is given by pediatricians. So you cannot take a 22-year-old to a pediatrician for a measles vaccine. And adult physicians are not comfortable and are not able to provide these vaccinations. Similarly, when a 60 or 65-year-old lady or a gentleman has to go to the US for delivery for their daughter or son, the US doctors insist on DPT vaccine or Tdap vaccine. And where do they go and take it? Tetanus is available, but what about Tdap, which is only given in children most often in India? So these are all the situations, and the barriers are mainly to do with improving awareness, because I find that it is unfortunately the healthcare workers, the family physician, the primary care physicians, the doctors who, because of lack of awareness, in fact, discourage patients who would like to take vaccines. So this has to change. The awareness has to improve. The availability of vaccines and the access to vaccines is probably the need of the hour. And hopefully at the end of the next 20 minutes or so, you will have a rough idea how you can help in this. We need to convert the current scenario where people are horrified about taking vaccines, but are very comfortable taking the same injections on their face. I think this concept has to change, and we need to improve the setting up of adult vaccination clinics. So what is necessary, or what is the prerequisite for setting up a clinic? You need to understand these are the various steps. You need to have an infrastructure, which means basically a large space. This should be an area which is accessible and available even for handicapped people, so that wheelchair access is there for these people who may be elderly to get to the vaccine center. There should be also resources involved with ordering and availability of vaccines, and also human personnel who may be required. The cold chain refers to the temperature controlled supply chain, right from where the vaccine is manufactured through to storage, handling, transportation, availability of storage in the place where the vaccine is given at the vaccine clinic, ensuring that the temperature is maintained in all situations so that the vaccines don't lose their potency. So this is the most important part of vaccine management. We have heard horror stories where earlier, at least I have heard over a decade, 15 years ago, when pharmacists used to shut off their refrigerators at night to conserve electricity and turn it on the next morning, and nobody would be the wiser. But unfortunately, the vaccines which have been stored here would all lose their potency. Waste management is very important, especially in an outpatient clinic or a vaccine setup. The administration of vaccines, I think the people who are conducting the clinic, we have to know, and I'll run through all these points subsequently. The timing and spacing of vaccines, the importance of vaccine information, how to get the message across to the patients, and standing order. Standing order is a concept which is mainly seen in the West, where the order says that unless there is a contraindication, all patients of a certain age or having a certain comorbidity will be given the vaccine if they access the healthcare personnel, whether inpatient or outpatient. So this is an accepted practice in the West, but in India, a doctor has to advise the patient to take the vaccine if he has to take the vaccine. So this may not be applicable in India. The importance of adverse event management. We are getting to know all these things with the COVID vaccines, because it's been very clearly said that if you need to take the COVID vaccine, you need to be observed for at least half an hour after the vaccination. And lastly, the maintenance of vaccine records. This is something which we cannot forget, because unless this is done, the follow-up and the future vaccination of patients may be jeopardized. So this slide very nicely shows the ideal infrastructure for a vaccination clinic. As I said, this is ideal. You need to have a waiting area, entry into the room for registration, health, height, weight, or blood pressure checking, counseling to be done, then move on to the doctor's chamber for examining the patient if it is warranted and prescribing the vaccine, payment counter, data entry, vaccination room, post-vaccination waiting area, exit. We also need to have storeroom for vaccines. But this, if you look at it, would probably need a space of about 600 to 800 square feet at least, which may not be practical. But it is very important that you have at least the ideas of a waiting room, a post-vaccine observation room, storage area for the records and refrigerator, and probably one area for counseling and giving the vaccination. This is the most important aspect of setting up of any vaccine clinic, what is called the cold chain management. It needs to start from the vaccine manufacturing, where it is stored, the distribution in a transport modality, which ensures that the vaccine temperature is maintained, the arrival, the storage and handling at the facility, and vaccine administration. All this has to be maintained at the ideal vaccine requirement so that the potency of the vaccine is not lost. And this gives you, for all people who may be dealing with vaccines, that there are several vaccines which are sensitive to heat and light. The maximum which may be destroyed by heat and light is BCG, oral polio, IPV, measles, and MR vaccines. So these are the vaccines, mainly all are live vaccines, which could be very easily destroyed by heat or light. If you are looking at temperatures, hepatitis B, PCV, and the vaccine, IPV, most of the vaccines which are given for children, these are all very, very susceptible to freezing. So it is very important that these vaccines, the proper temperatures between 2 to 8 degrees in most situations have to be maintained. It is very important, if you're dealing with vaccines, to know that the correct maintenance temperature is important, and you need to check for if there is cold damage in the case of freezing by the shake test. This is a very simple test where you shake and see whether it is uniformly distributed. If you find floccules or sedimentation at the base, it means that most likely this vaccine has been subject to too much of low temperature and may not be effective. So the cold chain vaccine sensitivities means keep all vaccines in the ice-lined refrigerator between 2 to 8 degrees. Use diluent provided by the manufacturer. Those vaccines which can be destroyed by heat or maybe light sensitive, maybe not only lose the potency, sometimes they may, because they don't contain preservatives, they can also have secondary bacterial infections like staphylococcus, which may lead to serious consequences when injected. Keep diluents by the manufacturer also at correct temperature. Use the reconstituted rotavirus, BCG, MMR vaccines, and JE vaccine within 4 hours. Beyond this time, contamination because of lack of preservatives may happen, and discard all damaged vials for disinfection and disposal. If you need to adhere to the cold chain, do not keep it in the cold chain, especially expired vials, frozen vials, or vials beyond the endpoint. Do not use rotavirus vaccine or other reconstituted vaccines beyond 4 hours, and do not dispose damaged or empty vials in the surrounding areas. These are mainly referred for if this is going to the village as part of a vaccination camp. These are all things to remember. The most important things with regard to storage of vaccines is store vaccines, only the vaccines in the refrigerator. You need to have a temperature log where you need to record the temperature twice a day at least. Open the door only when necessary. Keep the vaccine stored between 2 to +8 degrees. Don't store the vaccine on the door shelf. This is something which I realized quite late, just about a couple of decades ago, that vaccines should not be stored in the door of the refrigerator. Stock only 1 month's supply. Store full bottles of water on the empty shelves and on the door. Never leave vaccines outside the refrigerator and stock the vaccine on a first in and first used basis. So what goes in first should come out first, so that vaccines don't get stuck inside and reach their expiry period. You also need to understand that there are certain vaccines which can be kept in the freezer. The MMR, MMRV, varicella, and zoster, as I said, most of them are live vaccines. And this temperature should be maintained between -15 to -50. The other ones, most of them can be stored in the refrigerator between 2 to 8 degrees centigrade, which includes almost all the other vaccines. Waste management is a very important part of vaccine clinic setup. I ideally use only auto-disabled syringes. You need to cut the cutter, you need to cut the hub. Please, it's not just the needle, you need to cut it at the hub so that the needle can be disposed separately and the plastic hub can be thrown in with the other plastic. Segregate and store the cut syringes and discarded vials in a red bag. Send the red bag and the hub cutter for disinfection and disposal. Treat in an autoclave. This is mainly, as I said, in situations, maybe not even in the cities, where you may have less access to your good outsourcing of medical waste. Dispose needles properly, wash hub cutters with sodium chloride, and maintain proper record of treatment and waste disposal. This again highlights that the disposable syringes and broken vials and ampoules have to be discarded through the yellow bags and the needle sharps container. The plastic parts of the syringe and empty and broken vials in the red ones, and needle caps and other wrappers in the normal waste which goes to the municipal waste. So this is all part of doing a very proper adherence to the current recommendations. The route of administration of vaccines is also very important when you are dealing with vaccines and you're setting up a clinic. Please understand intramuscular, the syringe goes perpendicular into the skin. Never pinch up the skin, because when you pinch up a skin, what you think is intramuscular may be actually subcutaneous. Subcutaneous is given an angle, and intradermal actually is just under the skin, and you need a lot of experience, especially when you're giving rabies vaccines. This slide shows the various vaccines and their administration. Oral is by mouth. I want to highlight here that the cholera vaccine, which is actually a oral vaccine, sometimes is given by mistake parenterally. This has happened several times. So when you're using, which is very, very rarely used, the cholera vaccine, please remember, you take it in a syringe and push it into the mouth, not give it parenterally. Most the vaccines, most of the vaccines are intramuscular. A lot of live vaccines, including the herpes zoster vaccine, the IPV, the MMR, varicella, JE, all of them are given subcutaneously, and rabies can be given intradermally, but I said make sure that you are experienced in doing this. The live attenuated flu vaccine, which Vinay mentioned about, is given as a squirt inside the nostril. There is also necessity to understand the timing and spacing of immunobiologicals. If you're using more than 2 inactivated vaccines, they can be administered simultaneously or at any interval between the doses. But if you're giving an inactivated and live vaccines, similarly, you can give it at any interval. But if you're using 2 live vaccines, for example, a yellow fever, an MMR, or a chickenpox, or a zoster vaccine, then either you give it simultaneously or you need to give at least a 4-week gap. This is very important, especially if you're giving multiple vaccines for a child going abroad for postgraduate studies, where MMR vaccine, flu vaccine, maybe meningococcal vaccine, all of them are indicated. You need to give the live vaccines on the same day or at least have a 4-week interval. And similarly, if you're doing a Mantoux test, do not do it after you're given a live vaccine, especially the MMR vaccine, because it may interfere with the response. Again, please remember the vaccine schedule. Leave at least a 28-day gap between a Tdap vaccine and a tetravalent meningococcal conjugate vaccine. Again, there is a question whether PCV13 can be given with other vaccines when you're giving a patient with functional or anatomical asplenia. It is better to spread it out. And if you're using PCV and PPSV, as Dr. Aisha said, never give them together. There should be a minimum of 8 weeks. Preferably the PCV should be given first and then the polysaccharide vaccine. Oral typhoid and rotavirus vaccine can be administered subcutaneously, but this is in children. In adults, we don't use the rotavirus vaccine. If you're using antibody containing products and an inactivated vaccine, they can be given simultaneously. But if you're using antibody containing products with a live antigen, that is a live vaccine, then they should not be administered simultaneously, and the interval between the two depends on the dose of the antibody containing product. This is also important when you look at COVID vaccine, because when you have used a monoclonal antibody, there should be at least a 3-month gap before the patient can receive the COVID vaccine. This has to be kept in mind. This is again a simple chart which says if you're using antibody containing products and an inactivated vaccine where the inactivated antigen is given first, no interval necessary. If you're given antibody followed by the inactivated vaccine, no interval necessary. But if you're using a live vaccine and an antibody containing product, at least 2 weeks. And if it's an antibody containing product followed by a live vaccine, it depends on the dose of the antibodies given. It is also important to document the adverse events following immunization. Now, this is unfortunately something we have not been very meticulous when related to COVID, but these are the various categories of adverse reactions: vaccine product related, quality defect related, immunization error related, and anxiety related or coincidental effect. These are the examples: limb swelling following Tdap. Vaccine quality could be due to inactivated polio, which may actually lead to paralytic polio. Oral polio vaccine. Immunization error-related reaction is transmission through a multi-dose vial. Anxiety-related is quite often seen syncopal attack following vaccination. Lastly, but not least, maintaining vaccine records, the timing and documentation of what vaccine was given, and a permanent medical record is important. All this has to be recorded, mainly the date of vaccine, the manufacturer, the lot number, the name and address and title of the person administering the vaccine, and vaccine information system, whether it was informed to the patient. So this is all the theory of vaccines. But if you look at real life, when you plan all this, because I'm telling you because I have established several vaccine clinics, when you look at the expectations and plans, and when it translates to reality, this is actually what happens. You're faced with a lot of challenges in doing this. The practical issues may involve administrative tussles. What area you would like for the vaccine, which is accessible and which is in an area where a lot of people will congregate, the management is not interested to give you. I have had administration giving rooms which are under the staircase as part of the vaccine clinic because that is the least they can give. There is lack of coordination. The personnel is a problem. The nursing department will say, I'll give you a vaccine, but the nurse will come part-time just 2 hours. And you need a vaccine clinic, if it has to be effective, should be a one-stop shop where the nurse is available all through, and anybody can walk in, ask, and take the vaccine immediately. If they are going to wait for half an hour, 1 hour, it is very likely that they will leave and go to another place. So these are problems which I have faced. The pharmacy, will hesitate because there are legal requirements that the pharmacy, unless it is in the main part, if they have to establish a refrigerator which can store the vaccines in India, they should have a license for that area. So pharmacy will be reluctant to store the vaccine in the vaccine clinic. Billing becomes a problem. They will say the cable is not available. This is not part of the billing area. Most importantly, you'll have everything in place. Nobody is going to refer patients there because adult immunization, as I said, is a very, very under prioritized segment. Maintaining records will be a nightmare. We established the vaccine clinic. We started giving vaccine cards to the patients, but the next time they came, they will forget the cards. It is very difficult to ensure, but these are patients who are not admitted. They are coming for an outpatient follow-up, and having the records of these patients is very difficult. Even in patients, looking through the file to decide when they got the vaccine is a nightmare. And lastly, to ensure that this is self-sustaining and you're going to ensure good follow-up, all these can be very, very difficult in real life. So what are my tips to make it work? You need to convince the pharmacy and the administration that this is a venture which is profitable. The vaccine is given to the hospital at 50% or 60% of the marketing MRP, and whatever when you start pushing this, the margin is actually quite profitable for the pharmacy and the administration. So this is something you need to highlight. You need to make it a one-stop shop. When the patient comes in, whether he's referred, he's walking in, or he's been, he read it somewhere, he comes in, he says, I want a meningococcal vaccine. You say, okay, pay to the counter outside, come inside, I'll give you the vaccine, take the vaccine, wait for half an hour and walk out. You cannot ask the patient to go to the pharmacy, buy the vaccine and come here, go to another place for giving that is called the vaccine pushing charges or administrative charges, another 50 rupees or 100 rupees on top of the MRP for the provision of the vaccine or the administration, and then ask him to wait. It doesn't happen. We established vaccine counselors. We have one inpatient counselor and one outpatient counselor who works mainly with the master health checkup area, so that all the people who come through are given free counseling. The inpatient counselor actually counsels all the patients in the cardiology ward, the pulmonology ward, and the nephrology ward to tell them about the benefits. If the patient is amenable, the ward doctor actually tells them that they have discussed with the primary, who again, it's sort of by default, that if there is no contraindication, the doctor there will say, yes, this has been advised by your doctor, so we would recommend it, unless there are concerns which the treating doctor, the primary physician, can discuss. We targeted the various specialties and we kept the vaccine targets minimized. So the cardiology patient would get only a pneumonia and a flu vaccine. Similarly, the patient with chest would get a flu and a pneumonia vaccine. A patient with oncology or solid organ transplant would extend it to include hepatitis B or other things which may be necessary. And OBG, mainly Tdap and hepatitis B and flu. Diabetes similarly, and geriatrics. So we limited so that you didn't have all vaccines being counseled for all patients. If they belong to certain comorbidities, we limited the vaccine counseling and the administration to 2 or 3 vaccines at the most. All pre-surgical patients from tetanus, we changed to TD even before the government came up, and we are trying to push the Tdap because it's a little more expensive. Tetanus vaccine costs 10 rupees, a TD costs about 17 rupees or something, and Tdap actually may cost us as high as 600 to 800 rupees. All patients at discharge were advised the flu and pneumococcal vaccine depending on their comorbidity. This was reasonably easy because a lot of these patients were seen by the infectious diseases team. So our team, which had about 4 or 5 consultants, very aggressively recommended these vaccines to people on discharge. Employee vaccination also was made mandatory, especially for hepatitis B, chickenpox, and all of this was given only in the vaccine clinic. Vaccines were not available anywhere in the hospital, whether it was emergency, whether it was pharmacy, they had to come to the vaccine clinic to get the vaccines. And lastly, improving awareness amongst patients and doctors through billboards, through meetings with doctors, through pamphlets, all that helped to at least improve awareness and make things work. This is an example of our templates for transplant patients. So pre-transplant workup, all the vaccines and checkup which they needed. This is the vaccine card, Institute of Infectious Diseases adult vaccination card. This we insisted they bring every time they came. We also came up with stickers to put on the blue folder or the master file of the patient in the cover of the file, so that that was easily accessible and people, we knew what to do. So it is still a challenge. Adult vaccination is still in its infancy in most hospitals in India. And unless we learn to customize and think out of the box, we need to make it more attractive. We need to ensure that, as this card says, this is one of the fantastic things. Are you an alcoholic? We can help. We give free liquor home delivery. So you need to think out of the box. You need to ensure that all doctors are aware and vaccinate themselves and their family before they start recommending it to their patients. But once we have doctors who do it, they are real stars in the sense that they give the patient the best information and knowledge available as a proactive intervention to help improve outcomes. I'm going to stop here and I can take up questions.
Thank you, sir. It was an immense pleasure for us to listen to Dr. Ramasubramanian, sir, a different perspective for every physician. Sir had covered extensively about all the aspects of vaccination, especially the administrative part, the storage part, the minor things which needs to be addressed properly for effective vaccination. And sir, the vaccination card is available in any specific website, sir? Like for pediatric?
Yes, you have several websites. There is a website called immunize.org. This is a very useful website. And if you're interested in setting up a clinic, I think, though it is a little Western oriented, you'll get a lot of useful information from immunize.org. That's a very useful website.
Thank you, sir. I think doctors needs to be motivated, and the awareness should be within the doctors more than the patients to motivate the patients. Yes, sir. So, a few questions from the chat box, sir. In this COVID era, is there any possibility of sending the vaccine team to the home for adequate vaccination? How much it will be effective, sir?
This will be coming up in the COVID panel discussion we are having. Right now, it is essential that the vaccine for COVID patients only be given in accredited centers. So you cannot take the patient out of that or go home and give it. It is not yet recommended because of the side effects and other issues. But maybe the time will come when we have to give that at home. Flu can be given anywhere.
Okay. Next question will be any vaccination information sheets which explains the pros and cons of vaccine to your patient before giving vaccines. Do you have any pamphlets or?
We do have. It is all available in the CDC website. So you go to the Center for Disease Control website and vaccine information sheets for all vaccines with pros and cons. It's one-page sheet. Everything is available. You don't need to reinvent the wheel. You may need to tweak it a little, but all that is available as a baseline template.
Yes, sir. One more question, sir. Can we administer TT and COVID vaccine on same day for a pregnant woman, sir?
Yes, you can. Earlier, COVID vaccine, they said you have to have at least a 2-week gap between other vaccines. Now, CDC has said that you can give both COVID and any other vaccine on the same day. There is no issue.
Okay. Sir, can you briefly comment on the vaccination in geriatric population?
Geriatrics is a population which definitely need vaccines. These are elderly people who are having comorbidities like diabetes, hypertension, and several other conditions. And as Aisha said, the risk for pneumococcal infection and invasive pneumococcal disease stacks up. With each risk factor, the risk rate of getting complicated and poor outcomes goes up. So they will include annual flu vaccines. They will include definitely one Tdap vaccine, definitely a pneumococcal vaccine. If they are over 65, a pneumococcal conjugate followed by a polysaccharide vaccine. And if it is available or when it is available, the zoster vaccine. Zoster vaccine is unfortunately not yet available. These 4 vaccines I would strongly recommend for the elderly.
Thank you. Thank you for the wonderful talk, sir. Shall we move on to the next topic?
Ram Subramaniam, your physical or for physicians, you said, do the shaking, the freezing. Kindly tell us again. What do you mean by shaking and then find out whether it is freezer or not?
Some of the vaccines are destroyed by a very low temperature, but you can find out because if you shake and there are floccules or there are sediments at the bottom of the vial, that means that potency is lost. So they should it should uniformly distribute. It shouldn't fall floccules or it shouldn't form sediments. This is one way. There are also other indicators which we can use, but this is a simple test mainly for freezing. We check to ensure that it is potent.
What will happen if I keep vaccines which are supposed to be kept in 2 to 8 degrees in a freezer?
A lot of times, if that happens, you may lose potency. You may have to discard the vaccine. So that is why the cold chain maintenance is very, very important with vaccine efficacy.
Because many people over enthusiastically keep the vaccine in the freezer. So that should not be done because 2 to 8 means 2 to 8. People with Epizoster vaccine, MMR can be kept in the freezer, but not other vaccines to be in the freezer. So that's a very good point. And your point of keeping it inside, not in the door, is a very good point also because every time we do that and it's good. Very good, Ram. After your talk, I think at least some hospitals will take and initiate this vaccine center in their hospital at least. So let us hope and pray that it should be happening. Thank you, Ram. Good talk. Good talk. Thank you. Over to Master Ceremony.
I think next speaker is Dr. Ashwini. Ashwini is an infectious disease physician and she's working in Nagpur in a multi-specialty clinic. She's also very passionate about adult vaccination and she's going to talk to us about vaccinations for young women. I think that is something which is very, very important. Over to you, Ashwini.
Thank you, sir. Good evening, everyone. First of all, I'd like to thank SIDS and API Tamil Nadu chapter for giving me this opportunity of being this platform. And as sir said, yes, I am passionate about adult vaccination and Dr. Ramsubra is the reason for that passion. And I have started my adult vaccine clinic and I have faced all those problems which sir has already explained. So it's really a challenge to practice adult vaccination and to impart knowledge to people and make them start practicing adult vaccination actually. Okay. So moving on to today's topic, it's Olympic fever everywhere, and all of us are aware that all these girls have made us proud with the medals at Olympic. Imagine a situation wherein any of these was stuck and was not able to perform, might be because of chickenpox or something else. I don't think this is a pardonable situation, and in the era wherein we have wonderful vaccines available, it's absolutely not acceptable at all. And I don't imagine myself also in similar situation. So the topic today is vaccination in young women, deciding how young to call a woman, how women are young. It's really a difficult task. What I have chosen is teens, adolescents, and pregnant women specifically. So we know vaccines definitely works well, and they help us develop immunity against particular disease. They definitely lower chance of getting certain disease, and their complication like Hep B reduces the risk of liver related complications, liver cancer, failure. HPV vaccine basically reduces risk of cervical cancer, and flu, Dr. Vinay has covered wonderfully, definitely reduces the risk related to flu associated complications. We know all these vaccines, though we being young, we might be asymptomatic carrier, we might get mild disease, and we might not get severe complications. But yes, we are at risk of spreading this all these infections to our near and dear ones who might get severe complications related to disease. There's something called as cocooning, wherein like a newborn or elderly, these are the cases wherein they don't develop either the immunity or we cannot vaccinate them. So to protect them, we vaccinate the people who are in vicinity of this population, like we vaccinate the young who can be a symptomatic carrier. Travel vaccine or traveling, who doesn't love to travel, though unfortunately in COVID era travel is at halt. But yes, travel related vaccine, yellow fever vaccine, if you're traveling to particular area, definitely there is a list of vaccines which you need to fulfill, might be rabies, flu, or yellow fever. And pregnancy and vaccination is significant chunk of it. So when we know vaccine has to be given, we are aware that vaccines are safe. And with COVID, I guess all of us are aware about the procedure vaccine goes through. So all of these vaccines are FDA licensed. CDC and FDA do track their safety, and even post-marketing, their side effect profile is being tracked. Side effects are not significant, and severe side effect definitely are not significant. Minor side effect we do keep seeing, like fever, soreness, local swelling, redness, and all those. Yes, we do come across all these side effect often, but those are not significant, and those are definitely not, should not be a reason for not taking vaccine. So a case scenario which we are coming across now with COVID vaccine, young population is really enthusiastic about COVID vaccination. They are finishing their COVID vaccine, and now they want to know whether they need any other vaccine. So what will be our advice basically? So this is a CDC chart, CDC ACIP guideline, what we follow. So what is recommended basically is every year flu, which Dr. Vinay has covered. Tdap, once in lifetime booster. MMR, varicella zoster is basically for elderly. HPV vaccine is definitely recommended. Pneumococcal based on the risk profile. Hepatitis A and B, again, it should be recommended. And meningococcal and Hep B based on the risk profile. So I'll take one by one in subsequent slides. Flu, yes, Dr. Vinay has definitely covered, so we'll not talk much about flu. What I'll say is flu once every year, a yearly flu vaccine we have to take, because we know flu vaccine keep changing every year. And again, this year's another variant vaccine is available in the market. This was a Bangladesh trial, which was landmark trial for flu vaccine in pregnancy, wherein they have given flu vaccine and pneumococcal vaccine to pregnant population. And the outcome was basically significant reduction in respiratory illness in infants. So almost 29% of them decrease in the reduction for infant and 36% for their mother. In addition, there was a vaccine efficacy for confirmed influenza among newborn was 63%, which was a significant one. So this trial and many more studies have proven that flu vaccine, if given during pregnancy, definitely cut down on the risk of flu-like illness in newborn, and low birth weight incidence was significantly reduced. So what is recommended is a flu vaccine for all pregnant women, and irrespective of pregnancy, once in lifetime for all young women, once in every year, flu vaccine should be taken. Which vaccine has to be taken? So basically for India, it's a southern variant vaccine which comes in April. So it has to be taken every year. Tdap or tetanus diphtheria pertussis. So pertussis is something which is neglected, and we hardly taste for pertussis and we hardly diagnose pertussis. That is the problem with pertussis. But if we have look at institute data like AIMS, PGI, there are papers wherein they have reported incidence of pertussis. We do keep seeing diphtheria outbreaks every now and then. And basically the reason is poor vaccine coverage in pediatric population, and that is a reason we haven't reached herd immunity for all these diseases or all these infections. And we have to build up this herd immunity somewhere, and we are getting infections in young people, basically because of lack of vaccination in pediatric population. And that is why Tdap vaccine at this age, once in lifetime booster, is recommended. And the other thing we need to keep in mind is whenever we get this infection like pertussis in pediatric population or in infant, the severity of disease is significantly higher. So what is recommended is all teens we have to give booster for 11 to 12 years, and pregnant women basically between 27 to 36 weeks of pregnancy, we have to give one Tdap. And for adult, as I said, once in lifetime booster for Tdap is recommended. For those who haven't received Tdap during pregnancy, what is recommended is postpartum at the time of discharge, Tdap should be administered so as to pass on the risk to the newborn or cut down the risk of transmission to the newborn. And if you have received Tdap during first pregnancy, what about subsequent pregnancy? Yes, even during subsequent pregnancy, Tdap has to be given. What about safety of this vaccine? So this was a trial roughly around 70,000 women, wherein they have compared those with vaccinated and unvaccinated population, and the unexpected safety risk was hardly any. So this is a safe vaccine during pregnancy as well. So it's definitely recommended to all pregnant females and all young girls once in lifetime booster, and every 10 years we have to take TD booster rather than what used to take TT every 5 years. Measles, yes, we keep seeing measles outbreaks and measles cases. We keep seeing these newspaper reports wherein measles outbreaks are there. So there was a big outbreak of 3-4 years back in US. And even in our nearby areas, Maharashtra, Delhi, we have a lot of papers, publications wherein we see measles outbreaks. And India is amongst top 10 countries wherein measles is higher in the country. So look at this number, roughly around 66,000. India is topping all these countries when it comes to incidence of measles. Measles complication basically is higher in elderly population, and the complications what we see is basically blindness, encephalitis, severe diarrhea, and pneumonia. If we compare pregnant population versus non-pregnant population, the complication risk is higher in pregnant population like pneumonia, diarrhea, thrombocytopenia, encephalitis. And when it comes to passing on the risk to newborn, yes, the mortality is higher and risk of neurological complication like SSP is there. There is risk of miscarriage, stillbirth, low birth weight, and increased risk of preterm delivery. And that is why we have to give vaccination to all young women who are planning for pregnancy. So we have to vaccinate them with MMR vaccine. Another scenario which we keep which we see often in our OPD practice is like there is a high risk pregnancy, and then they come to you with history of fever, rash, someone in the family has fever, and we really don't know whether this fever is rubella. How do we manage her? Whether we offer her some prophylaxis, considering the risk of congenital rubella, do we need to advise termination? And since considering 34-year female high-risk pregnancy, advising termination is really a tough task. So all these are tough situations we face day in and day out. And what to do in all these situations? So basically, if we have a look at serology status of seroprevalence of rubella in our country, there are multiple papers wherein seroprevalence varies between 60 to 70 to 80% somewhere. So still there is 20 to 30% population who is at risk of rubella. What is the risk of rubella? If you have rubella during pregnancy, basically the risk is congenital rubella syndrome, which includes hearing deficit, ophthalmic complications, structural heart defect, hepatosplenomegaly, thrombocytopenia, there might be rash, microcephaly, meningoencephalitis, all these complications can be there. So basically MMR vaccine is a live attenuated vaccine. It's recommended, booster dose is recommended for all young females what is recommended is 2 shots 4 weeks apart. Contraindications will be pregnancy, those who have immunocompromised state, or egg allergy, basically because measles component, we have to get the history of egg allergy. The other thing what we have to do is either we can do the lab documentation like serology for measles, mumps, and rubella, or give the vaccine 2 doses 4 weeks apart. Chickenpox outbreaks are the ones which we are seeing, and particularly in summer season, we keep getting chickenpox patients. So this was a case which I had faced few years back. Close friend of mine had severe headache, fever, complete workup for fever was negative, CSF was suggestive of meningitis, lymphocyte predominant. MR brain was done, which was non-specific, and CSF PCR was suggestive of varicella zoster. In review of history, there was no vaccine given, and there was no history of chickenpox. So basically, this was just to emphasize the importance of vaccination, chickenpox vaccination, or the severity of disease what we can have in elderly population. What chickenpox we see in pediatric population is just rash and minimal complication. But when we have chickenpox in adult population, we do come across significant amount of complications in adult. Another scenario, basically what we face in chickenpox is a lot of issues related to infection control also. So this was a scenario I had faced. There was an outbreak of chickenpox in income tax department classroom, basically, and nearly 40 to 50 people were exposed, and majority of them were from out of this place. And as we know, chickenpox infectivity rate is really higher. So there were multiple issues related to how do you isolate them, what is the post-exposure prophylaxis we will advise them, how do we decide this clinical severity, and all those multiple issues, whether we need to vaccinate them, what about the rest of the people, how do we sanitize. So there are multiple issues which came across and which we had to tackle. So the risk, as I said, in addition to the serious severity of chickenpox, what we see in adult population, particularly when we have chickenpox in pregnancy, there is significant risk of congenital varicella syndrome, and the risk is higher in first trimester. So risk is 0.6% when it is 2 to 12 weeks of gestation, 1.4% between 13 to 28 weeks, and risk is nearly zero after 28 weeks. But then if you have chickenpox during earlier weeks wherein there is organogenicity, the CRS risk is higher, and there might be a severe CRS. What do we see in congenital varicella syndrome is basically low birth weight, cutaneous scarring, limb hypoplasia, microcephaly, cortical atrophy, chorioretinitis, cataract, and other anomalies. Chickenpox vaccine again is a live vaccine. It's recommended for adolescents and adult above 13 years without any evidence of immunity. So again, I had chickenpox in the past, is not accepted. There has to be a documented serology. Verbal documentation is not good enough. So either you have a documented serology or you advise them to get vaccinated 2 doses 4 to 8 weeks apart. What if first and second dose duration 4 to 8 weeks gap is not maintained? We don't have to repeat first dose and restart the schedule. We can give second dose as and when patient comes for the second dose of the vaccine. Next vaccine, what is important in this population is cervical cancer vaccine or HPV vaccine. So a young girl came to me for her father's checkup and she was enthusiastic about HPV vaccine. But then her doubt was whether do I need a pap smear before vaccination, and what are the vaccine choices available to her. And there was another scenario wherein one of my doc friends said her daughter took 2 doses of HPV and now she had gone abroad for education. She had missed her 3rd dose. So how do I plan her 3rd dose? So we know cervical cancer incidence in India is significantly higher, and India is second leading in female cervical cancers, female cancers basically. So HPV basically can give rise to non-mucosal cutaneous infections like warts or mucosal infections, which might be high risk and low risk, anogenital wart, recurrent respiratory papilloma, or high and low anal genital tract, cervical, oropharyngeal, penile, vaginal, vulvar cancers, etc. What is important is the HPV types which are associated with this. So with low risk, what is associated is 6 and 11, and with high risk associated is 16, 18, 31, 33, 45, 52, and 51. So all these are covered in the vaccines which are available. So we have 3 types of vaccine available: bivalent, quadrivalent, and nanovalent. Bivalent and quadrivalent is available in India. Nanovalent is not available in India. So basically this includes 16 and 18. Cervarix, Gardasil includes 6, 11, 16, and 18. And nanovalent includes 6, 11, 16, 18, 31, 33, 45, 52, and 58. Dosing remains same. Basically dosing depends on the age wherein we are starting the dosing for these vaccines, and all these vaccines are studying adequate number of population, and none of them have found to have any significant side effect profile, and all these vaccines are really effective. So as I said, do we need to do a pap smear before giving vaccine? We don't have to do a pap smear before giving vaccine. But yes, we have to keep in mind that it doesn't give protections against all type of cervical cancer. So regular screening post-vaccination is definitely mandatory and recommended, and we have to advise regular screening. So basically vaccine is recommended for 11 to 12-year-old. We can start as early as 9 to 10 years of age. Girls and women between 13 to 26 years of age have been recommended to complete their vaccine schedule. And CDC basically recommends vaccine to be started at 11 to 12 years of age, and 2 doses for them. So if you are starting at 15 years of age, the recommendation is 3 doses. And if you are giving before that, the recommendation is 2 doses. The idea behind starting it early is we have to give the vaccine before the person gets exposed to the virus through sexual activity. So 2 doses versus 3 doses, as I said, basically if we are starting it early, it's 2 doses. And if we are starting it above 15 years of age, it is 3 doses. 2 doses is basically first dose and second dose should be 6 to 12 months after first dose. And when we are giving 3 doses, it is 0, 1 to 2 and 6 month gap should be there. So if there is dose interruption, what should we do? Basically, between first and second dose, there should be 4 weeks gap. There should be 12 weeks gap between second and third dose, and 5 months between first and third dose. So like in situation wherein my colleague's daughter, I don't have to repeat her any of doses, and whenever she comes, I can give her third dose whenever she comes for the vaccination. So efficacy, as I said, this is one of the best effective vaccine available, and the efficacy is 98% somewhere. But yes, we have to keep in mind that it gives protection against the limited vaccine types which are available in the vaccine. Rest of the viruses, it doesn't give protection, and we have to keep that in mind and keep doing the follow-up pap smears regularly. What about vaccination in pregnancy? HPV is not recommended during pregnancy. Women known to pregnant should delay initiation of this vaccine until after the pregnancy. If you are found to be pregnant after starting HPV vaccine, delay the rest of the vaccines and finish them once the pregnancy part is over. Hepatitis B, there is significant amount of population who is been exposed to hepatitis B, and this is a vaccine wherein people are really reluctant. Even healthcare workers, so many of us students, they come to us that they have missed their doses and they are not sure what is the status of their next dose and how should they plan their dosing. So basically the type of hepatitis B vaccines are available are these 4. What is available with us is Engerix, Recombivax. The efficacy is roughly 95% and the immunity is at least 20 years, and there is an immunistic response. So now the guidelines are we don't have to give booster doses. Why is it necessary? Basically for pregnancy, if the risk of passing on to unborn baby is significantly higher and there is risk of prematurity, the risk is almost 85 to 90% to infant born to HB positive mother and 32% when it is HB negative mother. And risk of chronic HBV infections when infected during adulthood is 5%, which is significantly higher. And then there is risk of acute HBV progression, acute to chronic progression, roughly around 40% in hemodialysis patient, and those who are immune deficient, roughly 20% risk of developing chronicity. And that is why Hep B vaccination is recommended to all those who are at risk of acquiring Hep B. So what if there is interruption between the doses, and which is the commonest confusion for this vaccine? So we don't have to repeat any of the dose. The series does not need to be restarted and we just have to continue it. What we have to keep in mind is that second and third dose should be separated by interval of at least 8 weeks. And if only third dose is delayed, it should be delivered as soon as possible. Routine booster doses is not recommended. What is recommended is we just have to check their anti-HBs titer. If anti-HBs titer is about 10, that is good protective titer. And as I said, there is an domestic response and we don't have to repeat any dosing. Hepatitis A is one which is really neglected one, and we feel everyone in India is immune for hepatitis A, but that is not the scene. Epidemiology is definitely changing. There were papers initially that almost 80-90% of the Indian population will be immune by the age of 18, but the data is changing. So initially, like by 92, almost 98% of patients, people were seropositive by 6 to 10 years of age. But now there are multiple papers, one from Pune and AIMS as well, wherein it's just 50% of population is seropositive by age of 10 to 18. So roughly 50% of our population is still at risk of developing hepatitis A, and we know there is risk of fulminant hepatitis A, and those who have CLD, the risk of complication and fulminant liver failure is higher. So what is recommended is we do the serologies and advise them vaccination. It can be given as isolated hepatitis A vaccine, 2 doses, or we can combine it with hepatitis B vaccine. So just at a glimpse, what is recommended for all young women vaccination. So once in a year, influenza vaccine is recommended for everyone annually. Tdap or tetanus diphtheria pertussis booster once in lifetime. Every 10 years, it is TD. MMR for everyone should be either we have to check serologies or we have to give 2 doses of MMR. Varicella, again check the serologies, or if it is negative, we have to give 2 doses of varicella. But yes, these are live vaccine and we have to rule out immunocompromised state. HPV vaccination from 9 to 26 years of age. Those who are between 27 to 45 years of age, we have to discuss with clinician because the efficacy was found to be debatable, and then we have to decide whether to go ahead with this vaccination or not. Pneumococcal vaccine was already been covered, hepatitis A and hepatitis B based on the risk profile and your serology status. Meningococcal vaccine, those who are at risk or those who are immunocompromised have to undergo meningococcal vaccine. So I'm pretty sure quite a few of us have missed our opportunity, but it's never too late. And what is recommended is, like Dr. Ram Subbu has just covered, what we need to do is talk about vaccine to our patient, record the vaccination status and schedule further doses. We should have a checklist for specific contraindication. And it should be a habit to advise vaccination to all our patients, irrespective of the risk factor or irrespective of the reason they are coming to OPD or they are getting admitted. If we develop that habit, I guess writing vaccination and improving the adult vaccination coverage will be definitely a easier task. So she had done her job by giving awareness about this our breast cancer. I tried my level best, and I'm still doing my level best to improve awareness about adult vaccination. So it's never too late to get vaccinated. We have to keep doing our job and I guess get our shot whenever it's available. Thank you.
Okay, so I think that was a very comprehensive talk, Ashwini. There have been several questions which have come up. I will say a couple and then maybe Darshini can say a couple more. I'm deleting the questions which are going to be discussed later in the COVID panel and in the post-exposure listing tomorrow. A lot of questions in this. Is Tdap, if you give it in one pregnancy, when is the next, what about completing the course? When should you give it next?
So when we take Tdap in first pregnancy, if you are planning your second pregnancy, yes, you have to take Tdap during second pregnancy, again 28 to 32 weeks. And if there is no second pregnancy, then every 10 years, TD booster we will have to take, tetanus diphtheria booster.
And the patient received Tdap and after 2 months, she sustains an injury. Do we need to give TT?
We don't have to give TT. So it's every 10 years we have to give.
Darshini, any questions I have missed?
Yes, sir. Almost covered everything, sir.
There's one question
Next,
here. Role of HPV vaccine after 26 years of age.
26 to 40 years, yes, there are trials wherein they have found efficacy, but then efficacy is debatable. So we have to discuss benefit with the physician, because the basic concept of HPV vaccine is you have to give vaccine before you are exposed to the virus. So by 26 years of age, you are already exposed to the virus. So the benefit will be lower. You won't get that 98% efficacy after that age. So you have to keep that in mind, and then yes, you can advise vaccination to that age woman.
Anything, Darshini? Do you think there's any more?
Yeah, nothing else. Which HPV vaccine gives maximum protection against cervical cancer? Is it available in India?
It is nanovalent, but it's not available. So what is recommended is quadrivalent. For boys, basically quadrivalent and nanovalent is recommended. For girls, all 4 vaccines are can be given, whichever is available. So what I recommend, what is available to us is quadrivalent. So that is what I recommend as of now.
If a woman comes,
Yes.
Go on, Darshini.
Yes, sir. Yeah, is there any role for TT for like injury, ma'am? Acute injury?
There is no role if we are vaccinated. If we have taken Tdap and if we are taking TD booster every 10 years, then we don't have to take TT every time we get injury.
If a woman comes with a history of taking 1 dose of HPV and before the 2nd dose she becomes pregnant, when is the next dose given?
So next dose will be after completion of pregnancy. She'll have to resume her 2nd dose, and 2 doses or 3 doses depends. Mostly, presuming she is pregnant, she must have started it after 15. So she'll have to take 3 doses. So next 2 doses after pregnancy.
Yeah, thank you. I think that's all the questions are, Ashwini. Thank you very much.
Thank you.
I think the last session for today, over the next 45 minutes or so, is going to be the panel discussion. I think there have been a lot of concerns about vaccinations for COVID, and I thought I would moderate this talk. We have 3 eminent people on the panel: Dr. Ram Gopalakrishnan, who is a senior consultant in the Department of Infectious Diseases at Apollo Hospitals, Chennai. Dr. Suresh Kumar, who is also a consultant in infectious diseases and tropical medicines in Apollo Hospital, Chennai. Both of them are my colleagues. And Dr. Tanu Singhal, who is a consultant in pediatrics and infectious diseases at Kokilaben Dhirubhai Ambani Hospital, Mumbai. So I welcome all the 3 panelists. Right. And we will start. I would like the audience to put their questions. There are 2 things. If I think we can stick to one, maybe we'll stick to only the chat box, so that if anybody has questions, they can put it in the chat box and I will take it as we go along. I've got several questions which I've already picked up. So, and we will start with that. Is Dr. Suresh Kumar? Yes, Suresh has just joined. Nick of time. Yeah, Suresh, maybe you should unmute yourself also. And the first question I'm going to start with Suresh is, there's a lot of concern and, I wouldn't say coercion, but there is a lot of incentivization and, strong push towards vaccinating for COVID everybody. So the question is, it may sound a little silly, is the vaccination the only way forward for defeating the pandemic? What is your view, Suresh?
Yeah, good evening, and I thank the organizers for giving this opportunity. Before I start answering a couple of disclosures, I don't have any shares in any other vaccine companies or any shares anywhere. And all my opinions are personal or my startup, what I belongs to, best of IDs. And whatever I'm talking, I got evidence based. So everybody want to know, I can send the evidences behind it. Yes, regarding your questions, whether vaccine is only the answer for ending the pandemic, I don't think so. Vaccine plays a big role. I agree with you. Vaccine plays a big role. Apart from the vaccine, we know in the year 2020, without vaccines, how we control wave 1. The non-pharmaceutical interventions we call masks, social distancing, and most important in wave 1, we learned ventilations. We need to move out. That plays very important role. Apart from the things what we know in wave 1 and wave 2, apart from the vaccination, testing is going to help out. So test as much as possible, as many times possible, and isolate the patients who got tested and who got tested positive, treat them also. That's going to help out. And third thing is antivirals. Any antiviral that clears the virus immediately, that is going to play a big role in ending pandemics. So we need to have a good antivirals that need to be identified. So far, there is no good antiviral so far identified. And as Jeremy Fra, the Welcome Trust Chairperson clearly told, to get away with pandemic, we need to investment in science. We need to invest, we need to do a lot of research to find out what is the best strategy to end the pandemic, not the vaccine alone.
Okay, thank you, Suresh. So yes, vaccines are very important, but we also have to do other things. Now over to you, Tanu. When the mRNA vaccines came up, they were the first vaccines which were licensed and received emergency use authorization. There were a lot of queries about whether this mRNA would take over your nuclear, genetic structure and then start reprogramming and you'll turn into a monster and stuff like that. I'm putting it in a lighter vein. So do you believe that the mRNA vaccines are like that? They've given excellent benefits, but in the long run, there is still a lot of reservation about the long-term side effects of vaccines. And apart from mRNA, there are other vaccines also which are showing side effects. So what do you think of side effects in general about vaccines?
See, the most common side effects with the vaccines are the initial reactogenicity when patients have pain, fever, and with those side effects are actually most common with the viral vector vaccines, followed by the mRNA vaccines and then the inactivated vaccines. But we are really more interested in the serious side effects. Now, with the mRNA vaccines, there is really no reason why they are going to integrate with our genome because it's an mRNA vaccine. It doesn't even go into the nucleus. And it is enveloped in a lipid nanoparticle, and it is so fragile that it has to be stored at -20. So there's no reason that this mRNA is going to hang around in your body for a long time. So I think that worry which we had about the mRNA vaccines is not true, that they'll have any long-term side effects. And we must remember that into, even phase 1 trials, and they've not noticed anything serious so far. However, with the mRNA vaccines, the two major side effects which have bothered people is one is the risk of anaphylaxis, which was noticed with both the Pfizer and Moderna vaccines. And recently with this side effect of myocarditis, which came to the fore in young men. However, this myocarditis was also mild and it resolved with NSAIDs. But again, there is a concern whether, there would be a long-term effect on heart function. Now, with the viral vector vaccine, the significant side effect which people are talking about is the risk of the blood clots or the vaccine-induced thrombocytopenia, which is actually very dangerous because the risk is about 1 per 100,000 doses as estimated in UK, Europe, and Australia. And maybe 30 to 40% of people who have this side effect die. So actually, that is the most serious side effect which we are looking at with the viral vector vaccines, and of course, some cases of Guillain-Barré and encephalitis. The inactivated vaccines actually are this form which we've been using for a very long time. And we know that there are no unintended effects which will come. The only problem is that their efficacy is not as great as the other two vaccines.
Right. Thank you, Tanu. I think Tanu raised a question of risk of clotting with vaccines. Gopal, I'm going to ask you, there is a lot of concern about getting yourself tested for CRP to see whether you have a raised CRP, which would indicate the possibility of something going wrong post-vaccine. So before the vaccine, do you think any test is necessary, whether it is antibodies, whether it is CRP? Does it have any role to play in the complications which may arise after the vaccine?
No, there's no role for routine testing before a vaccine. The only issues that you need to go into before you give somebody a vaccine are the patient's past medical history. Is there a history of anaphylaxis to any vaccine in the past? Is there any general history suggestive of clotting disorder or something else which might potentially be related or unrelated? If it happens after a vaccine, if supposing somebody has had recurrent DVTs in the past, and you give that patient a vaccine and they develop a blood clot later, it could just be their propensity to develop a blood clot which has caused it. So these are the things, it's a medical history that you'll have to go into. There's no role for a routine blood test before you give somebody a vaccine. There's also no role for doing COVID antibodies before vaccination, because it's been clearly shown that if you've had natural infection, whether you know about it or inadvertently, just giving one dose of vaccine skyrockets your antibody titer manyfold. So it's really beneficial, actually, if you've had inadvertent infection, you didn't know about it, you're COVID antibody positive. So all standard guidelines just ask for a medical history, not really a test before vaccinating.
Okay. Thanks. I'm going to follow up with another question. You know, this risk of clotting, we know definitely, as again Tanu mentioned, that the risk of clotting is much higher with the Covishield, especially in younger women. When you're talking about women less than 30, the risk can be reasonably raised in such people, what is called the VIPIT, the vaccine-induced thrombotic immune thrombus, whatever it is. So there is a risk of higher risk of clotting happening in younger women. So do you think that younger women, on one side, we have lack of vaccination going on the other side, the risk involved? So what would you advise for younger women, somebody who's 35, somebody who's 25, you know, somebody has to go abroad? Do you advise Covishield, or would you advise a non-Covishield option if it is available? And if there is no option, only Covishield is available, what would you advise?
I would recommend whatever is available. If the only vaccine available were Covishield, I would certainly advise it. It's been well shown that the risk of complications from COVID, as well as blood clots from COVID per se, outweighs the risk which Tanu mentioned, about 1 in 100,000 or so of COVID. Having said that, if there is a choice between two vaccines, both are equally available, both are licensed for travel, etc., or if somebody is on oral contraceptives, has had DVTs in the past, then possibly I would recommend a vaccine other than the AstraZeneca vaccine. But that's a clinical decision across the board. It's most important to get vaccinated rather than worry about what vaccine you're getting.
Right. I think that's the message. Suresh, we are in the midst of the pandemic still, whether it is second or third or whatever way, and a lot of people are coming down with COVID. So two specific questions. If I have COVID today and I've recovered, how soon can I have the vaccine? Because the government says wait 3 months. But suppose I have to go abroad after, say, 2 months for whatever reason, I need to get the vaccine in. So a lot of people are afraid to take the vaccine. How soon can you take the vaccine? That is number one. Number two, I've had 1 dose of vaccine today. I end up with COVID next month. So I need my second dose probably in 2 months' time. When would you suggest I take the vaccine?
So regarding your first questions, what to do there? So ideally, once a person got infected, the immunity can last little longer. How long the immunity is lost longer? Recently, the data has got published. Minimum 146 days. A couple of days back on preprint as well as publication came. Up to 146 days, you are protected following single infections, but it can last up to 7.7 months according to Nature publication there. So data shows anywhere between 146 and 7 months you are protected following natural infections. Not everybody. So whether to go standard dictum of 3 months following infections by Government of India, or according to CDC, once you're recovered from the illness, because the data clearly shows the reinfection rate following one infection is almost 2. The odds of getting second infections or reinfection is 2.34 times. Yesterday's MMWR, if you read, 2.34 is a reinfection risk for people who are infected there. So what I would advise is, once you're recovered completely, there is no signs and symptoms of infection, that is the time you need to take the vaccine. That is the time to take the vaccine to improve your immunity. That's the thing. And regarding the next question, I have taken 1 shot of vaccinations. Now I got COVID. Again, what to do? People are talking about taking the vaccinations following COVID. Only 1 dose is recommended, because studies have clearly demonstrated after COVID, if you take 2 doses of vaccinations, the antibody titers, there is no big difference. If you take 1 dose, the immunity will boost it much, much higher. But if you take the second dose, the level of immunity, what you achieve with 1 dose is equal to the second dose. So I don't think so. But for this question, I got vaccine, I got infected. Naturally, the titers will last longer, but there is no data following this type of scenarios where first taken vaccinations, second infection happened, what will happen? But usually I follow the same dictum for the previous case. Once you got infected, despite take vaccinations, consider the same rule of the previous rule of not vaccinated and got infected there.
So there is no harm in taking the vaccine earlier than 3 months, and there is no harm in taking 2 doses, even though you say 1 dose is adequate, 2 doses. Fine. Tanu, there is a lot of concern about anaphylaxis. I think Gopal mentioned that anaphylaxis in the past is only for vaccines, but I still hear every day I see one person at least who comes saying that I'm allergic to prawns, I'm allergic to sea fish, I have had anaphylactic reaction to sulfur, to penicillin. And unfortunately, when these people go to a vaccine center, The doctors there say, no, we can't give you the vaccine. You had a history of anaphylaxis. What do you advise?
Yes, so actually the first point which I would like to make is that many people are not taking the vaccine because of all these issues. They are on medication, so they feel they can't take the vaccine. They are having some disease, they can't take the vaccine, or they've had a history of allergy in the past and they can't take the vaccine. So the only absolute contraindication to the COVID vaccine is if you've had an anaphylactic reaction with the first dose. That is the only absolute contraindication. Otherwise, all the others are relative contraindications, and we have actually given vaccines even to people who have had anaphylactic reaction with measles or MMR vaccine in the past. We've gone ahead and given it to them. The only point which we tell is that we at least in our hospital, that when these patients take the vaccine, we make sure that all the material or the kit which is available for managing this anaphylactic reaction is available, so that in case something happens, we are able to do it. But I always encourage people who say they have history of allergy to sulfur and all to go ahead and take the vaccine, because again, it is a question of risk versus benefit. We have to choose the option which is less risky. And I feel that with COVID all around, it is much safer to take the vaccine than to worry about the risk of anaphylaxis, which is actually easily treatable in a proper setup. So what I would also advise these people is probably to go and take the vaccine at a proper hospital or a private or corporate hospital where, adequate facilities for managing an anaphylactic reaction are available.
But is it common? Have you come across any anaphylaxis with the currently available vaccines in India?
No, we must have vaccinated, we vaccinate about 500 people a day in our hospital over the past few months. We've never seen a single case of anaphylaxis, at least with us.
Yeah, Suresh, you wanted to say something?
Regarding, people are asking, because in corporate hospital, what Dr. Tanu said is easy to follow. We know what we are doing it. Unfortunately, most of the primary health centers also, they're giving vaccinations. Small centers, they're giving it. So I follow the rule, 3 rules I say, CDC rule says, if the allergy is known to insect or food or latex particles, please go ahead and give. Even for oral tablets, please go ahead and give vaccination. There is no contraindications. Don't ask me for phone anything. If the person has got injectable drugs allergy or any allergy to previous vaccinations, please contact the local physician before, because nurses are running the clinic. They need to call the physician and check with the thing. When the person develop reaction to the first dose of COVID vaccine, please call the ID. That point of time you disturb me, I'll answer the thing.
Very practical answer. Thanks, Suresh. Gopal, a lot of people have issues getting the second dose of the vaccine, even though we now know that Covishield does give excellent response if given after 3 months. There are issues about accessing. So some of them, they've missed the 3 months. They don't get the vaccine, they wait longer, or they may have had an infection in between and have already gone 4 or 5 months after the vaccine. And this could be Covaxin or Covishield. So what do you do then? Do you restart the schedule? What is your advice?
No, you just take the second dose as soon as you can get it. So if you've had an infection and you're better, go ahead and take it. If you've had COVID, the government says you wait 3 months after COVID, but that's more a public health advice, just to preserve stock of vaccine. Soon as you're better, clinically better, get it. So preferable to take whatever vaccine you got the first time, because there's maximum data on trials, etc., with the same vaccine used together, rather than mixing vaccines on which there is emerging data, but nothing in the form of guidelines or concrete recommendations.
Right, we will come to that in a minute. But the bottom line is take it whenever you can. Just take it. Don't go about repeating schedules. Suresh, you mentioned about the role of you have certain specific sentiments, and you clearly said that these are mine and there is evidence that 1 dose is enough. But now the stress is 3 doses. I'm getting again every day people ask me, I've had 2 doses. It's 6 months over now. I had it in February and finished it by February. So 6 months down, I'm 65. I've got diabetes, hypertension. I want to take the 3rd dose. What do you say?
You are asking about the 3rd booster dose, but the problem is this is a lot of ethical issue is facing. Right now, so much of world does not even receive 1 dose of vaccinations. But unfortunately, Israel, German and France people start vaccinating. Above the age of 60 people, they start vaccinating. Almost Israel has completed 11% of above 60 with the 3rd doses. Why? They're feeling the effectiveness of vaccine has gone down with 2 doses, but there is no data. The same doses of vaccinations, what we are using for the alpha variant, what was introduced, whether it's going to prevent extra doses, third dose if we give, it is going to prevent the Delta. There is no data so far. But despite the thing, because the effectiveness against Delta has came down very much low in Israel, they started vaccinating above the age of 60, hoping the third dose might protect. But if you see the entire world or even entire country, even not even one dose is received by so many people with a lot of shortage for the vaccine. So clearly the WHO chief has clearly put on the strategy of vaccinating third doses right now, vaccinate everybody with one dose. Because everybody is protected, then only are protected. Don't think the third dose is going to be protected. If the entire world is protected with at least 1 or 2 doses, then only the third dose. So there is no need for third dose. Suppose if you go ahead and vaccinate the third dose, whom we should want? Data shows clearly people who are immunocompromised. Yes, the benefit might be, benefit is there. People above the age of 60 or nursing home residents, they call, the benefit is there. And I told earlier, the vaccine immunity is lasting up to 146 days. So people who are vaccinated 6 months above, the chances of getting booster doses might help. But we need to know what dose you want to use or what vaccine you're going to use. That's a big question and big challenge is going on. So these are all the selected populations. If you got adequate stock of vaccinations after vaccinating most of the people with one dose.
So we still don't have data, but this reminds me of what again my mother used to say: if you don't finish the food on your plate, think of all the Ethiopian children who are starving. It's like that. It's very difficult ethically saying that in my country it is available, so why would I bother about a country where it's not available? Anyway, those are difficult.
No, I just want to make a point that practically it's not possible for anyone to take the third dose because, all vaccinations are through the COVID app. And once you finish both your doses, you cannot take the third dose.
I think you're not living in India, Tanu. We are in a situation where you can get anything done in India. So I beg to differ. Tanu, the question comes now. Okay, you're bothering about elderly people, you're bothering about sick people and, comorbidities, but it's the children, they are staying back from school. They are not getting their school. They are psychologically traumatized. So children need vaccines. And I get, somehow I get all the nasty questions. My son is 17 years old. I want to give him a vaccine. Don't worry, doctor. I can get him any vaccine, you tell me. I need to give it. So what is your opinion on pediatric vaccines at this point in India?
Yes, so again, I'm going to first say that children actually have very mild COVID. They contribute only.
No, but the third wave, it is believed predictions are that you'll get.
No, that is completely wrong. That's completely wrong. The first point which I want to make is that was a very loose statement that if the third wave comes, it will affect children preferentially. The first wave and the second wave have been the same for children. And we know children have immature ACE2 receptors, so the virus cannot enter and it cannot cause severe disease. And unless the virus changes its nature a lot, children will be mildly affected in the third wave. So that's the first point which I want to make. And also the National Seroprevalence Surveys show that the degree of infection in children is the same as in adults because people thought that children were staying back at home. So they didn't get infected, but the percentage seroprevalence is same 60% as in adults. So it's that children have also been asymptomatically affected. And the severity of disease is less in children. So children are a lower priority for vaccination as compared to adults. Because again, there are ethical issues which come up. If you've not even vaccinated adults in our country, how can we think of pediatric vaccination? And that's what the WHO is also saying, that children are at a lower priority for vaccination. However, this issue is there that they're not going to school, but there are many countries which have managed reopening of schools with other measures. So adults get vaccinated, the teachers get vaccinated, the frontline workers get vaccinated, children adhere to masks, etc. So it is possible to open the schools without, starting pediatric vaccination. And the way I look at it is that pediatric vaccines will be probably available next year, because we will vaccinate a substantial amount of our population by the end of this year. And the vaccines which will be available for pediatric use are the DNA vaccine from Cadila, because that will probably be the first vaccine to get licensed because their trials included children above the age of 12 years, followed by Covaxin. And then the Covovax, which is the Novavax, which is being developed by Serum Institute of India. So these are the 3 vaccines. And of course, if the Pfizer and Moderna vaccines become available in India, they will also be available for pediatric vaccination.
What about the issue of myocarditis? There is again a new panic that, okay, you say give, it's licensed and give it, and my kid is ending up with myocarditis.
Yes. So as I said that, there's no intervention which is going to be completely safe. So we have to decide, what is more risky. And that is why I said that for children, we don't need to be so worried right now. It is much better that we look at we look at the data a little more carefully. We look at the safety data carefully before we start immunizing children. And in my opinion, the safest vaccine for childhood for pediatric vaccination will be either the inactivated vaccines or Novavax. Because they are Novavax is like a subunit vaccine, which is, we have experience with hepatitis B. So they would probably be the safest for pediatric vaccination.
Gopal, you said there is no role for checking antibodies before the vaccine. But one of the things which again I come across is the husband comes and says, my antibody titer after 2 doses of vaccines is only 2.4. My wife's is 250. So I want to take another dose. So what do you advise people who want to keep checking their antibody? And this is not one, they keep checking it every month to see whether it is waning and whether when they need to take a booster. So what do you tell them?
So I tell them, if it ain't broke, don't fix it. So we don't know a lot about what actually constitutes functional immunity against COVID. What actually prevents corona? Is it the serological response in terms of antibodies, or is it a T-cell mediated response? All the studies on vaccines look at both arms. And whereas you only measure a commercial IgG antibody level when you ask for a test, you don't even do neutralizing antibodies. That's not commercially available. So the standard recommendation is, even if you don't have antibodies, you could well have cell-mediated immunity to the virus, which will protect you. And even if you have a very high titer of antibodies, you may not have cell-mediated immunity, which may be the true correlate of protection. So the standard recommendation is, don't check. Just vaccinate, don't check.
Right. What is your idea of mixing vaccines? For whatever reason, for availability, non-availability, so I take first dose of Covishield, I want to take a Covaxin as a second dose.
Now, nobody likes to go to work in the same dress every day, right? You like to change your dress every day so you look a little bit different. So I think mixing vaccines is entirely appropriate if there is a shortage. For instance, the country of Bhutan, they did their first vaccine with Covishield, and then they ran out because India couldn't export to them. So they got a lot of donated mRNA vaccines from the West, and they completed their entire country's vaccination using a different vaccine. That's appropriate. It's better to always take some vaccine than no vaccine.
Is it safe? Is it safe?
Yeah, regarding the safety standpoint, I think there are emerging studies. There is one in Lancet, there is one in New England Journal, which suggests you have good immunogenicity and no apparent safety concerns in the small number of patients who are studied. These were 150, 200 patients, certainly not the large numbers of patients that you put in randomized controlled trials using a single vaccine, 2 doses. So it seems to be safe, it seems to be effective, but you really need a larger trial proving that it is better than standard of care. That's the other issue. Is it better than taking 2 doses of the same vaccine? We don't know. It could well be. So as of now, just follow standard guidelines in whichever country you live. In India, that's 2 doses of the same vaccine.
Right. Suresh, we are now entering the flu season, at least in Tamil Nadu, and the monsoon has already started in Maharashtra and Kerala. There's a lot of question about concomitant vaccination, and children are going abroad now for their studies, and a lot of them take multiple vaccinations, including COVID. So what do you advise them? The 2-week gap you advise them? Do you advise concomitant vaccines? What do you say?
Yeah, when the vaccine recommendations came initially, when Covishield and Covaxin were introduced, they want to give a gap of 2 weeks to know the assess the side effects profile of Covishield and Covaxin. But it's now clear that whatever the side effects are, reactogenicity side effects, we are able to identify now. So there is no need for any time gap. If you want to give both the shots also on same day, it's fine. There is no data against using the 2 doses on same day. You can give both the vaccines on same day. Or if you want to separate out for 8 hours later, also is fine for me. There is no data against separating out for 2 weeks. That's initially we was wondering what side effects we are going to face, what are the reactions going to happen. A lot of confusion was there initially, but now it's all sorted out there.
Right. Tanu, you are the queen of variants. You did a fantastic session in the SIDSCon, this clinical SIDS webinar on variants. There's a lot of now Delta has come, Delta Plus has come, and maybe Delta 2+ may come tomorrow. What is the role of vaccines in this situation? Do you think we need to wait for a better vaccine? Would you think we need to take our dose and sit tight? Do you think we need to take extra doses?
So, fortunately, at least till now, whatever we know that these vaccines also do protect against variants. For example, I'll talk mainly about Covishield. We know that 2 doses of Covishield give 60% protection against infection with the Delta variant, but 90% protection against hospitalization, which is pretty decent. And we know that even with Covaxin, it gives about 60% protection against the Delta variant. So, something is better than nothing. So what I would probably say is that we have to take these vaccines because they do give some immunity against the variants. Of course, it's been shown that the mRNA vaccines give better protection against the variants than the viral vector and inactivated vaccines, because just the amount of neutralizing antibody titers that you generate with the mRNA are higher. So higher your antibody titers, better is your protection. But all these vaccines give variable protection, but they do give protection against the variants, and that is the best chance we have. And that is also the reason why people are talking about booster vaccinations and heterologous vaccinations, because by giving extra doses, you will up your protection against the variants. And also, the vaccine companies are trying to devise the new probably remain ahead of us in this case. They will probably, a virus will develop a variant earlier than we develop a vaccine for that. But still, people should think that they have given decent protection. We really don't know why the AstraZeneca vaccine didn't do so well against the beta variant in South Africa. But now that variant is not really circulating anymore. So that was one exception where it hardly gave any protection. But otherwise, all these vaccines, at least the mRNA and the viral vector vaccine, give protection against the variants.
Right. Gopal, any thoughts on the future of vaccine schedules or vaccines regarding variants? Any thoughts you would predict?
I think the nearest analogy to COVID is influenza. In influenza, as you can see, we need an annual vaccine because the strains keep changing every year. So unless you develop a so-called universal influenza vaccine, that is not going to change. And that's what they're working on. Similarly, unless you develop a vaccine against COVID to something other than just the spike protein, which seems to be everything for the virus, both from attachment to immune evasion, etc., then you'll probably have to devise new vaccines every year and revaccinate everybody every year. Also, the technology we're using is an intramuscular technology, which is quite similar to what we do for influenza. It's not like measles technology, varicella technology, where you give live virus. So you're probably going to see an annual COVID booster every year. Also, now the data says your vaccine-induced immunity wanes annually. So I would actually predict that maybe 5-10 years down the road, we'll have a combination shot of a flu shot and a COVID shot. Just like the kids get multiple vaccines, 3, 4, 5 vaccines in one dose, pentavalent, etc. You might well see a situation where you have to annually take a booster every year with a flu shot and an updated COVID shot based upon circulating strains, new variants, etc. That's just a guess.
Suresh, there is a lot of noise about the role of flu vaccine or pneumococcal vaccine in giving you protection from COVID. There are a couple of papers which have said that people who take the flu vaccine have a lesser chance of suffering from COVID. What is your thought on that?
No, these are all very few papers. We can't quote with a few papers data there. There is no real data showing flu and pneumococcal will prevent COVID. Maybe following COVID, we can prevent streptococcal pneumonia, or following COVID can prevent influenza. It won't prevent COVID. And regarding the variant, what was Dr. Danu was talking, just now we got a message. It's a hot test. J&J has got approval in India. Ministry of Health and Welfare has given approval to J&J vaccine. And the good news is J&J has got published the data of South African data. Yesterday it got published the data. What it shows for beta variant, the J&J is not good. For Delta variant, it has got 91% efficacy. Against South African variant, J&J is not good. But for a Delta variant, J&J is good. Fortunately, J&J has got approval today. So it's a hot topic for tomorrow. People are watching that. This is the 5th vaccine approved by Ministry of Health and Family Welfare. Even though Moderna is not available, but still J&J, what time it's going to be available. One-shot vaccine is coming to India, and it has got very good protection against hospitalization. For infection, 71% efficacy. For hospitalization, 91 to 96% efficacy against Delta.
So does it mean that if I've had my shot 6 months ago, I should now go for my J&J shot?
For that, you need to go for the Lancet paper. It shows clearly people who have taken Covishield, if you take mRNA vaccine, you've got a very good immunogenicity. It has got a safety data, almost 430 odd people, they analyze the data. But for people taken Pfizer vaccine, if you repeat the Covishield or Covaxin, there is no big immunogenicity data, even though it passed overall cutoff. But people taken Covishield or adenovirus vector-based vaccine and taking Pfizer vaccine of B&T, you got a very good immunogenicity. But people taking B&T and subsequently there is no much antibody booster. But we need to wait for more data for J&J.
Thanks, Suresh, for the hot news. Tanu, what is your view on the vaccine passport? You know, there is a vaccine passport which has being strongly pushed about. So do you think that we should all go for a vaccine passport? Tanu?
Yes, I think in times to come, it is going to be a necessity. And hello?
Yeah,
hello?
Maybe you cut off your video because there's some connectivity issues, I think.
Can you hear me now?
Yeah, we can hear you now.
Yeah. So as I said, this vaccine passport is going to be a necessity, you know, in times to come. And right now, the biggest necessity is for travel. Because, you know, we already see that, you know, countries are not recognizing Covishield and Covaxin, like UK, etc. And therefore, traveling of Indians is going to be a difficulty. So I think the vaccine passport is going to become important in times to come, as far as travel, access to places, etc. And it is also going to incentivize people, you know, to take the vaccine, because there are many people who don't want to take the vaccine. And if these vaccine passport is introduced as an essential thing, then more and more people will take the vaccine and as well.
Right. No, I think on paper, what you say is very nice. So going over to you, Gopal. Now, I think vaccine passport makes sense, you know, so you take the vaccine, you are at least in certain level protected. But what complicates matter is the fact that some vaccines are recognized by some countries and some vaccines are not recognized. So if I've had my 2 doses of Covaxin here, I may have the antibody protection or whatever. But if I'm going to say UK or US, they say, no, nothing, you can't, we don't approve of it. So how do you think we should deal with that? Do you think that then we should go only for the approved vaccine? Do you think that, you know, this is a policy question, but I would like to know your thoughts on this.
Yeah, first of all, WHO is against vaccine passports for reasons of equity. They believe that large parts of, say, Africa and other poorer countries don't have access to vaccines. So it is ethically unacceptable to introduce vaccine passports. So that is WHO's position, and there's certainly excellent logic to that from their standpoint. On the other hand, for reasons other than travel, for instance, social meetings, restaurants, for instance, or going to a movie theater or a public congregation, it makes sense for you to have proof of vaccination. It certainly reduces your risk and reduces risk to everybody around you. And I think it is time that WHO drew up a list of approved vaccines, which is just the case. They have a standard list of approved drugs to treat COVID, for instance. So if they could easily introduce a certification process saying X vaccine has gone through the trials and it is found to be immunogenic and safe, and if somebody has taken this vaccine, it is acceptable as a so-called vaccine passport. But at the moment, they are against so-called vaccine passports. They say it is completely unfair for developing countries.
Okay, there are several questions which have come up in the chat box also. So I'm going to now go a little faster. I want you to spend not more than 30 seconds. I'll go in turns. So starting with you, Suresh, the government guidelines of Himachal explains that vaccinated persons need not undergo RT-PCR even if outside home state. Do you think it is scientific?
No, it's not scientific. Vaccinated people will still develop infection. So once you suspect person clinically infected, we need to go for a RT-PCR, provided the person has got symptoms. And regarding this vaccine passport, Kerala has introduced, even if you want to step out, you need to have a vaccine passport, not for travel. If you want to step out of your house to go to some place, we need to show the vaccine passport. I have completed 2 doses to avoid social gatherings. Yesterday, the health minister in Kerala Assembly, they passed, people want to step out, they need to have 2 doses of vaccinations, or we need to have other option, do PCR test.
But do you think they have enough vaccines to justify this rule?
That is a hot topic. Yesterday, we had discussions in the media. They are not provided a vaccine. Who is going to pay for the PCR? That's a big hot topic. But that is a vaccine passport you're talking and just mentioning it.
Okay. Tanu, do you believe that home vaccination should be introduced? If not now, at least when the vaccine availability is increased so that more people can avail of it? Because I found that the problem with not taking vaccine is not vaccine hesitancy, it's vaccine apathy, where you just don't feel like there are too much of complications involved in going and getting the vaccine. So if you simplify the process, you send somebody home to do it, they are willing to pay. Do you think that should be approved?
I think that should be approved, because so far the biggest risk of home vaccination is that of anaphylaxis, which we are not seeing too much. So I feel that home vaccination should be approved, and especially for people who are very frail, who cannot move out of their homes, who are handicapped, who are elderly, because it is also going to mitigate one more risk, and that is the risk of acquiring COVID when you go to a vaccination center. So I think home vaccination is a good idea. But again, there has to be, there has to be some kind of regulations for it, because, in Mumbai, we had these camps organized in various societies where even, false vaccines were given to people. So that is also a problem with home vaccination, and you have to look at ways to circumvent that, because, you may get a fake vaccine at home. That's a problem.
Gopal, person on anticoagulant, would you give him vaccination? Is there any precautions? Can you give it subcutaneously? What are the options?
Yeah, if it's say an acetrom or a coumadin warfarin type anticoagulation, you check the INR. If the INR is more than 3, you withhold the anticoagulation temporarily till it falls to less than 3. If it is less than 3, you can go ahead, advise a fine needle and advise extra pressure till there is no bleeding after the vaccination. If you're on antiplatelet agents, you can just straight away go ahead, aspirin, clopidogrel, etc.
Thanks. Tanu, your opinion on vaccinating pregnant women?
Yes, so I think pregnant women should be vaccinated, because in the second wave, we saw that pregnant women who had COVID had worse outcomes as compared to non-pregnant women. The problem is the data. So while there is animal data available for the mRNA vaccines, and there are a large number of people in the West who have been vaccinated with the mRNA vaccines and have not had adverse pregnancy outcomes, we don't have that much data for the viral vector vaccines. The government has given a go-ahead for viral vector vaccines in pregnancy, but the issue is, one, that these women fall in that age where the risk of clotting is high. And the second is that they are already in a prothrombotic state. So, there may be a higher risk of, getting a serious reaction or a clotting problem with the viral vector vaccines. Therefore, personally, I advise pregnant women to go in for the inactivated vaccine if that is available. But I think pregnant women should get vaccinated.
Right, but there is no definite guidelines to support you.
So the government says, and what we would say in this platform is that pregnant women should be vaccinated because the risk of COVID is higher than the risk of vaccination in pregnancy, and take whichever vaccine is available to you. But on a personal note, I would probably recommend inactivated vaccine like Covaxin to these women.
Right. Suresh, do you think people who are splenectomized should be vaccinated? Is it safe? Is it beneficial?
Yes. Splenectomy is one of the immunocompromised conditions we call, and we recommend certain special vaccines for splenectomy patients. So COVID also need to be taken. Definitely they're supposed to take. There is no contraindications.
What about if they are on steroids?
Yes, people who are taking steroids or immunosuppressions, a lot of guidelines is available depending upon how severe the immunosuppression is. Particularly the rheumatological societies have come up with some guidelines when to stop the biologicals, if possible, to stop the immunosuppressions or not. But as far as steroid is concerned, usually if the person is taking more than 15 milligrams of steroid for more than 2 weeks, the chances of getting immunogenicity following the vaccination is not great, but it's not a contraindications. You are not going to produce adequate immunogenicity, but definitely it's not a contraindication. So you can go ahead and take. If possible, you can cut down your steroids or immunosuppressions, if possible. If not, go ahead and take the vaccinations.
Tanu, when can I donate blood after I've taken the vaccine?
There is no contraindication to donating blood. You can donate your blood at any point in time after vaccination.
Right. Gopal, somebody would like to know your views on Covaxin, Covishield, Sputnik.
Go for Moderna. Sorry, I actually meant that all these vaccines are good. Any vaccine is better than no vaccine. In terms of efficacy, probably the mRNA vaccines have the best efficacy data. So just take a vaccine. Don't worry what vaccine it is.
So,
yes, Tanu, you want to say something?
yeah, so I mean, I usually have a table in my mind when I talk about these three vaccines. So what I say for Covishield is that the advantage is that its efficacy is proven. There's a large data which is available, and the fact is that it is approved by the WHO, and your vaccine passport will be recognized. The disadvantage with Covishield is the side effect of blood clotting and the fact that you have to wait for 3 months to complete your schedule. As far as Covaxin is concerned, the advantage is that it's a known platform, the side effects are less, and you can complete your schedule in 28 days. But the disadvantage is that it is supposed to be less efficacious than the other vaccines, and second is it is not approved by the WHO. And as far as Sputnik is concerned, I say that the advantage is that it's like Covishield, which you can take 28 days apart because it's a viral vector vaccine, which is efficacious. You can complete your schedule in 28 days. But the downsides are that it is not approved by the WHO. And also because the data about Sputnik is not widely published, or we don't have a lot of effectiveness data about it. So that is the kind of understanding I have in my mind about these three vaccines. And that's how I sometimes tell people, who are really prodding about how you compare the vaccines.
Before Sputnik, I used to say, one is a love marriage, other is an arranged marriage. After the marriage, both are got same effects. So go ahead and use whichever you want to do there. But Sputnik is living in relationship, I think so. It's not before marriage or after marriage.
Thank you. That's very interesting, all three summaries. Suresh, the person has developed the first dose, a reaction after the first dose, say thrombocytopenia or clotting after the first dose of Covishield vaccine. What would you advise as a second dose?
Usually the studies demonstrated 2 doses, better efficacy, better prevent the hospitalizations and death compared to 1 data. So we need to go for clinically how significant is the anaphylaxis reactions or whatever serious side effects, what they consider. If it is a life-threatening, I don't consider the same. Right now, mixing data is coming up. So if the person taken Covishield and person life-threatening serious infections, I would consider providing a second mixed variant, other vaccines if possible. Suppose if the option is also not there, and if it is a life-threatening, I don't consider again next dose of same vaccine.
Right. Tanu, I don't know how they get these questions. A child or an adult has developed a multi-system inflammatory syndrome after COVID. Would you vaccinate the child or the adult, and if so, with what vaccine?
Yeah, I mean, we would go ahead and vaccinate because there's no data about, the vaccine triggering another episode of multi-system inflammatory syndrome. So I would go ahead and, because this is not applicable for children so far because we don't have childhood vaccination available, but for the adult, I would still go ahead and, offer them the vaccine.
Gopal, again, the antibody question, which would give you the best antibody? What can we do to improve antibody levels?
Don't measure antibodies. Simple answer.
FDA is clearly told there is no role of antibody measurements. FDA has given a clear-cut warning. Don't go by with anti-spike or anti-neutralizations because in Indian labs, a lot of neutralization titers is available. This is not a real neutralization data, what we are getting it. People are not understanding. In fact, people going by the neutralization titers, they expose and get infected. They think they are protected and they're not wearing a mask and they're not wearing adequate protections. They're getting infected. We have seen a lot of people recent times, 2 doses, immunity is good. They started all sorts of things and getting infected now.
I just wanted to bring your attention to one paper which was published today in, I think, JAMA or NEJM, where they looked at an Israeli study where they looked at healthcare workers who got breakthrough infections after vaccination, and they found that the anti-spike IgG titers were lower in the people who got infected versus the ones who were not infected. So, so that is just one set of data which shows that there is a correlation, but unfortunately, we don't have a surrogate level, a level at which you can say you are protected or not protected like you have for hepatitis B.
Thank you. I think there are several other questions, but a lot of them are overlaps. What about pregnant women, breastfeeding women getting vaccinated? What about people who are taking NOACs? What is a favorable trimester of pregnancy for getting married? Getting vaccinated. So I think the basic question is just take the vaccine at the earliest. Whichever vaccine is available, take it and make sure you complete the course. And in spite of vaccination, ensure that you continue to wear masks, especially when you are in crowds, and avoid crowds. I think that's a message. Can we store an opened vial for the next day? Anybody wants to take it?
No, I mean, we shouldn't be storing the vial for the next day.
Okay, so I think it's past 9 o'clock. I'm going to call it a day. I think this was a very interesting session on COVID vaccines. Thank you for all the panelists who very actively participated and gave advice. I'm going to ask Dr. Muruganathan whether he has anything to say at this point.
Yeah, only thing, please log in at 8:55 p.m. or 8:55 a.m. tomorrow, because there are a lot of interesting, again, on COVID related also, because you can ask any questions on COVID also, because any vaccine now, there will be no question, there will be no place for other vaccines except the COVID. They will ask you, can we give rabies vaccine along with COVID? They'll ask you whether we can take healthcare workers COVID vaccine with other vaccines. So I think tomorrow at 8:55 p.m. please join. And we have got interesting topics like vaccines for healthcare workers, vaccines for immunocompromised persons, vaccines in pipelines, travel vaccines, and a panel discussion on pre and post exposure to vaccination. Believe me, this is the first time we are having a conference on vaccines. So it's high time that everybody should know about vaccines. And please join us tomorrow at 8:55 a.m. All the panelists and experts will be there. Even Ram Subramaniam will be there. All our good friends will be there. So you can ask questions the whole night. You think what questions to ask tomorrow. Please join us at 8:55 a.m. So this is my message. And of course, the COVID vaccines discussions was very good. There are so many questions unanswered. Maybe one or two questions which are not unanswered, we will always put it in the WhatsApp and answer. Maybe all our friends, I have got about 15 WhatsApp groups, Ram Subramaniam. So many people who are participated in this program is our WhatsApp group people. So I will request Ram Subramaniam and Suresh, some of the questions which are not unanswered, you please answer them. I'll give you the question and we'll put it in the WhatsApp so that they'll be happy that their questions were answered. And one more question they always ask, suppose, in the private sector, they'll go to the home or the company, they take the 10 vials and they vaccinate 120 persons. So that means they give only 0.75 ml. And for that, we have no answer. But there is a paper saying that if you give first dose 0.5 ml and second dose 1 ml, it is good. So any comment on this, Ram Subramaniam, from your side? First dose 0.5 ml, the second dose 1 ml.
We can ask the panelists, sir, but the question of having extra doses, that happens, there is always a little bit of extra. If you say 10 doses and we expect, say, for example, 10 ml, actually there is 11 ml. So you can, by giving.
No, I agree. It's 11 ml is okay. But one vial, they, vaccinate for 15 people or 14 people because, they go to the company and they do it. But my own satisfaction is okay. Even then, if 0.5 ml is there in the first dose, it's okay. So your opinion, because there was a paper saying that the first dose 0.5 ml, the second dose 1 ml. Suresh, what is your opinion about this 0.5 ml and 1 ml?
Actually, the second dose, if you reduce half the dose, now the paper is there, particularly people considering booster doses. If you give half the dose, following the two full doses, if you give half the dose, the immunity is much better. Immunogenicity is much better if you give half the dose. In fact, initially, Covishield paper also, the dose has got a lot of confusions. But now paper is coming up, first 2 doses, full doses. If you give half the dose, particularly if you're using a Moderna vaccine, the immunogenicity is much better against Delta variant.
Because this question is asked by the industry people, because all my Tirupur industries, they give vaccines up to 2,000 people, 3 days, 4 days, and nobody to supervise. So they are, little worried whether they give little less vaccine, especially in your case. The second dose, if it is less, it's okay. The first dose, it should be full 1 ml. So we must make sure at least 1 vial, not more than 11 patients. So that is the bottom line, and we must say check for that. So that's one way of, as fake vaccines are there, even the measurement is also important. I think we had a very good discussion. I think Ram Subramanian, I must congratulate you for the excellent speakers you have arranged. For the scientific program is done by you, and all of them are excellent. I think tomorrow also we are going to have a good scientific feast. And I only request the Seshadri, because many people have asked me in my personal WhatsApp, can we have this video recording in the module? So if you can give the recording, maybe we can put it in the website, and people who have not come, they can download and listen. If Ram Subramanian agrees, I'll ask Seshadri to upload.
On YouTube, sir. All our programs are available on the YouTube, so anybody can access it. They need to put it as a SIDS webinar, and then they will be able to access it. So that will be done, sir.
Very good. Thank you, Ram Subramanian. So looking forward to meet all of you at 8:55 a.m. tomorrow. Thank you. Stay safe. Good night.
It starts at 9:15, sir. So I think by 9:10, if they are join that day, that's fine, sir.
Okay. Oh, it's
Thank you.
9:15.
Thank you very much.
9:15. Yes, sir. இதுன்னது
$440 சார். அதுக்குள்ள $500 கொடுத்துட்டேன். கொரியர் 150 லட்சத்துல $100 கொடுத்தாங்க. அது அப்புறம் இந்த சேர்த்து